All right. So we welcome you to the Concept Academy. You just need to be you need to be very relaxed. Like just be very relaxed. Before we start, USMLE. I'm very sure everyone that is here has it in mind to write USMLE. If not so, most likely you won't be here. You see, USMLE is actually a very, very simple exam. Like, very, very simple exam. Don't be carried away by what most people are saying out there. The reason why many people find it difficult is because they used to think that you need to know a lot before you write USMLE exam, which is not so. As a matter of fact, whether you are a first timer to USMLE or you've been reading USMLE before, the thing is that if I should put up 100 questions here, I'm very sure that some people, despite the fact that they've never studied for the exam before, they will still be having up to 60 something or so. So the reason why many people find it difficult to really go along, with USMLE is because they approach it in a complex way. So, when you think something is quite difficult, even if they give you simple question, you will still be looking at that simple question in a very difficult way. You can bear me witness to this. In school, when a professor that you know most of the time asks difficult questions, even when the person is asking something simple, you will be like, there is most likely a catch there. That is not USMLE for us. So that's not USMLE for us. So all you need, basically, in the cardiology that we are going to unravel for you, is just for you to have an idea of how USMLE will test each area. You see, in the exam, they may not even ask you up to 10 questions in cardiology. So more than 90% of what you read, they won't ask them. More than 90% of what you study, no one will test them in the exam. So what they will test is basically simple stuff. So they may just pick the heart now and just ask you about just talk about MI and ask you, okay, which artery is affected in this patient. So if you look at it critically, you realize that it's just something very simple. And if you ask most people that are writing the exam, you realize that, to be very sincere, what they ask in the exam, they are not difficult. I'm giving us this preamble so that when we start the lecture, we start listening to the stuff, you will be approaching it in a very simple way and be like, okay, this is what they may test here. And if I thought there is anything that is quite difficult for you, don't give yourself any headache with respect to it. Do you get me? You can just ignore. You can also learn how to ignore things. Just ignore and just put it aside while you just move on with the other aspect, because you may not be tested on that particular thing in the exam. All right. So we are the Concept Academy. We train you to actually approach USMLE with ease, and you are going to see, we are going to demonstrate that for you basically today. So enjoy, get yourself a cup of coffee, sit back while you enjoy the Cardiovascular System USMLE Step 1. All right. All right. Good afternoon, everyone. So this is the Concept Academy. USMLE 1 Rapid Review Pro. We want you to be well relaxed. Sorry, can you all hear us? I hope you are hearing. Can you hear the?
Sir.
Lovely.
Yes, sure.
Be
We can hear you,
very,
sir.
very relaxed so that you'll be able to get the gist of what is going on in the USMLE step 1. Then another important point to pass across to us all is that give us these 6 to 8 weeks, flow with the way the program is organized for you, and let us see what you are going to get out of it. Because if you do not really focus on what we are doing, you are not going to get the gist of what we have for you. At the same time, be praying for us, because your prayer will go a long way in us actually helping you. All right, so we are going to be starting with cardiovascular system. We have a long way to go. Your writing material is important. If you have your first aid, get it. If you do not have first aid, try to get one. Because you will need to be actively engaged or involved in the study. We are not going to be moving stuff here, but just to simplify the important concepts that we all need for the exam. All right, sit back and relax. Let's dive into cardiovascular system. So this is the first aspect, the cardiovascular embryology. What do you want to take into the exam with respect to cardiovascular embryology? Number 1 is, at what week do you think the heart is going to start beating? And that is going to be the week 4. Very simple question that anyone can answer. Then the second important question you might want to note here is about, at what week do you think the beating of the heart can actually be detectable via the transvaginal ultrasound? So you go for week 6. Now, if you look at it, week 4, week 6, just for you to note, very simple question, then you move on. The next important concept is about the cardiac looping. So the cardiac looping, at what week do you think the cardiac looping is going to begin? The same week 4. So not many numbers, just 4 and 6 to be playing around with. So the last concept here is about this protein called dynein. You can write it down and rehearse around it. Dynein. This dynein is important in the proper orientation of the heart, which means that the way you know the heart to be positioned, the protein that helps in that proper positioning is this dynein. If at all there is any defect in this dynein, the heart is going to be abnormally positioned. And that's just the question. They might just give a question of a patient with dextrocardia, where the apex of the heart is pointing, let me say, to the right. So when they give that kind of question, the next thing they will test there is that, which protein do you think is defective in this patient? The answer is dynein. Very simple and straightforward. So don't complicate it for yourself. USMLE is not a syndromic exam. They hardly test syndrome. Hardly. If at all you see any question that is predicting syndrome, that such question is hardly USMLE. So what USMLE does is to bring it down to a very simple concept that can you even reason it out. So cardiogenic syndrome can be portrayed where you have all manner of ciliary dysmotility. So they will now add to that question that they also discover that the heart is abnormally positioned. Immediately you see that in the exam. Now say, what do you think is actually the origin of the problem? Anyhow the question can be So the question might be related to this dyne. When we are doing biochemistry, I will throw more light into this dyne. Very simple and straightforward. Shakener. You come down to the septation of the heart, of the chambers of the heart. Everybody will agree with us that we have atria, we have ventricles. So how do we divide the atria into the right and left? The process of dividing the atria and the ventricles, they are not going to really ask it, but it's quite simple enough for you to understand. So, and I want you to follow the explanation. Very easy and straightforward. The most important structure here that if you enter into that exam and forget it, no one will forgive you. It is what we call endocardial cushion. You don't want to forget this name at all. That is what they are most likely going. If at all they want to test anything with respect to embryology here, which structure is very important in the proper septation of the heart? Endocardial cushion. Very easy and straightforward, most especially the atria. All right, that's one. Where is this endocardial cushion here? This is it. Can you see it? This is it. So what is it going to do? We have this septum primum. Primum is talking about the first septum. The first septum. Primum, primary, first one. This septum primum is going to start growing towards this endocardial cushion to cover up what? Ostium primum. Ostium means O. So this O, first O you see here is the ostium primum. First O. Then septum primum, first septum. So it will now be growing down towards this endocardial cushion. Now let me set a question here. You just say that, okay, there is a drug that is developed that the adverse effect affect the endocardial cushion. With respect to the septation of the atria, which of the following structure do you think the drug is likely going to affect, or something like that? This is more or less like a signal that is directing, that is telling this septum primum, oh yeah, be coming towards me, be coming towards me. So if the drug is affecting this proper septation is likely going to be affected. Septum primum is likely going to be affected. You can look at it like that if you wish. All right, so it will continue to grow towards this endocardial cushion to cover it up. That's that. So as it's covering this ostium primum up, this one is going to be closing up. Now, there is a problem, or not technically a problem, more or less like the embryology process that also occurred there, and that is the death of the cell within this septum primum. Can you see? As they are growing, we just notice that the cell within it, they start dying small. When they are dying, they are going to create O within the septum primum. We call those O, second set of O, we are seeing ostium secundum. Can you see? Second set of O, ostium secundum. All right. This ostium secundum now, God look at it and it's like, why is the O coming in again? Let us cover it up. So, and that is going to lead to septum secundum, second septum. Oh yeah, you should grow and cover up the ostium secundum. Can you see it? Now growing and coming down here. All right, so we have the septum primum, septum secundum, ostium secundum here. Can you see? As this septum secundum is growing, it's going to eventually overlap this septum primum here. Just look at this diagram that I circle here. It's going to overlap it. So by the time it overlaps it, it's going to cover it up. It's going to cover it up. Now, this place is highly clinical. You cannot go into the exam and forget this area. The reason is that there are a lot of clinical conditions that you can peg on this area. So this small O or this small entrance that you can see here that is formed by the overlapping of these two septa is called the foramen ovale. I know you've heard about it before. This foramen ovale is supposed to be closed, and what closes it is actually the fibrous tissue. If at all there is a situation where it doesn't close, we are going to have what we call patent foramen ovale. patent foramen ovale. This is where it comes from, and that is that. All right. So look at this fifth diagram. You can see the foramen ovale is already closed. What is closing it here? Fibrous tissue. All right, that is just a process. You just need to have an idea about it, or what is going on here and the likes. So what are you expecting from them in the exam? What you are expecting from them is a condition called patent foramen ovale. What are they going to set about it? And the condition they are going to link to this patent foramen ovale is what you call paradoxical emboli. So I wrote something here. You cannot enter into the exam and forget the concept of paradoxical emboli. The normal emboli or embolism that you are aware of is like a patient having maybe something in the heart or something in the venous system. Now is dislodged, like a thrombus is dislodged and is now going to find its way into the heart. When it finds its way into the right part of the heart, it will eventually find its way to the lung. So it shows that if at all we have a venous embolus or venous thrombi that is now dislodged, so if it's dislodged, it's supposed to go to the lung. That is your expectation. So what is now paradoxical? That venous thrombi that is dislodged, you now start seeing it in the arterial systemic circulation. How does it get there? How does it leave the venous system and get into the arterial system? Likely there is a hole in the heart that is allowing it, and that is how the question will be portrayed. So any question you read and they are telling you that this patient has a stroke, more or less like a ischemic stroke, and you do not know the source of the stroke, you check through the whole body, you are not really so sure where is this thing coming from, most especially the heart, you may start suspecting that, we are not dealing with patent foramen ovale, and I will explain to you why. You have checked through the heart, you are not seeing anything as such. Why? Because these two septa, they overlap. So when you look at it, you might not really see anything that is quite obvious in the patient when you are looking at the patient's heart. Because they overlap, it will look like they are close, whereas they are not close. The fibrous tissue, it's going to look like fibrous tissue is there, whereas it's not really there. Do you get me? So when you see anyone with stroke, you do not know the source of the stroke. You check through the question, you are not sure. They say this patient does not have, you check through the heart, no, you are not dealing with atrial fibrillation, you are not dealing with all manner of stuff and the likes. You start suspecting patent foramen ovale. Just pick that as the answer and move on. And that's that. That is paradoxical. This is the most likely condition they will peg on paradoxical emboli. Now, another condition they can peg on it is what we call atrial septal defect. Atrial septal defect, what does it mean? This is the atrial septum. Can you see? So if I thought there is this defect is now maintained, it can be within the primum, it can be within the secundum. So if the defect is maintained, you say the patient has atrial septal defect. There are some attributes you will see in question that will tell you that this is atrial septal defect question. We are going to get to that. Please just note this paradoxical emboli. A patient with a venous thrombus that is now developing something like arteria, stroke or something like that, you see that kind of question, just move towards the paradoxical emboli patent foramen ovale. Now that is for the atria. So all the questions they are going to be setting on that, they won't really go beyond that. Come down to the ventricles. What do you want to take into the exam with respect to the ventricles? The same ventricles you know. We have the right, we have the left ventricle. Now, what is separating those ventricles? We have this interventricular septum. Now, when you mention interventricular septum, how is it formed? We have two portions of interventricular septum. We have the muscular portion, we have the membranous portion. They hardly test anything on the muscular portion. Can you see the muscular portion here? It's very muscular. The membranous portion is here. most of the questions you are expecting them around the membranous portion. Most of what they are going to be testing. Number one, where is membranous portion formed from? The membranous portion of the interventricular septum is formed from aorticopulmonary septum. It's not a big name. When you look at the ventricles, the outflow tract you have on it, you have the aorta, you have the pulmonary trunk. So the septum that is more or less like separating those two major trunk is actually the aorticopulmonary septum, like something that is dividing them. All right. So from it, you have this membranous portion actually growing from. So never forget this at all. And when you are also making reference to the septation of the ventricles, you also make reference to the endocardial cushion. So if at all you now enter into the exam, you now forget endocardial cushion, you deserve to be crucified down. Because you can't go there and they are mentioning endocardial cushion and you're like, I don't know, I've never heard of it before. That would be a dangerous game. So that is that aorticopulmonary septum. Now, apart from where the membranous is formed from, is there another thing you want to take into the exam? That is the site of ventricular septal defect. The same ventricular septal defect you've all heard about. This is the site. So they can just give a question about a patient that has ventricular that has, let me say, holosystolic murmur, that is hard at the tricuspid area. I will show you all those stuff. You will get used to the murmur. All right, they just give you that kind of question, and the next thing is that where do you think, what's the embryological origin of this murmur or something like that? So you now be making reference to a defect in the membranous portion of the interventricular septum, Shikena. So these are the major things. You don't need to sit down and start cramming the diagram because these are just diagrams to illustrate. These are the few points you want to take into the exam with respect to ventricles. Very simple and straightforward. I'm quite specific so that you are not going to overread. You come down to the outflow tract formation. If I ask now that what are the outflow tract of the heart, everybody will shout the aorta, the pulmonary artery. God is so wonderful. Now this is actually the outflow tract. Let me write them. Let me draw something for you. Let me assume that this is the pulmonary artery. This is the aorta. I want you to follow me very well. So look at this septum here that is dividing them. That, okay, let me say that this is what we call the truncus arteriosus. This is how everything is before. Then we now divide it into two. Let us have the pulmonary artery. Let us have the aorta. So the important cell they are going to test here that helps in the proper division of this truncus arteriosus is actually the neural crest cell. Now, this is where the neural crest cell is creeping in. So you must never forget it because they will just give you anything related to abnormal division and the other stuff I'm going to mention. Once you are seeing it in the question, you don't need to really understand it that much. Just go and pick neural crest cell. So if the question says that maybe the pulmonary artery is narrow, the aorta is now very big, they now say, where do you think the problem is coming from? The answer is neural crest cell. They tell you in the question that the arrangement of the pulmonary artery and the aorta is quite abnormal. Which cell, where do you think the problem is coming from? Neural crest cell. Neural crest cell helps in the proper division of these truncus arteriosus. That's number one. There is another thing we call spiraling, the way they arrange themselves around themselves. Think about it. Between aorta and pulmonary artery, which one is stronger? Which one is thicker? It is actually the aorta. You imagine big shoe and one particular wrestler that is very thin. If you are God, how are you going to place them in such a way that both of them will not suffocate? You are going to tell Big Show, you should lie down. Let me place the other wrestler that is not big. I will place that person on the big show. That's what you will have done. That's what I will have done. And that's the same thing God did. God actually put aorta down and now placed the pulmonary artery on top of it. Because aorta is very thick, the pressure in it is very high. If you should place aorta on top of the pulmonary artery will be narrowed. So if they now talk about the arrangement of the pulmonary artery, and I don't think you need to think it wide and be sweating in that kind of question. Just be like, okay, pulmonary artery is supposed to be anterior, while the aorta is supposed to be posterior. Shikena. Because if it's posterior, pulmonary artery is anterior to it, it shows that there will not be pressure effect on the pulmonary artery. So they now give a question where that arrangement is distorted. The question now says they notice that their pulmonary artery is posterior. Aorta is now anterior to it, on top of it. Where do you think the problem is coming from? Neural crest cell. They are not properly arranged. Very easy and straightforward. So these are the 2 points a few points you want to note about the outflow tract, spiraling, and symmetrical septation of the two of them. So in any condition you have ever seen before, or you've had it before, that you notice that they are not properly arranged, or something is wrong with the normal arrangement, just be thinking towards neural crest cell. As you have in transposition of great artery, they are switch, neural crest cell problem. Tetralogy of Fallot, neural crest cell problem. Persistent truncus arteriosus, so septation is not occurring there, neural crest cell problem. Shikena. Do you think you need to read wide before you answer these questions? No. So you come down to what we call the valve development. Valves? Yes, valves. All those valves you've heard about. The aortic valve, the pulmonary valve, the mitral valve, the tricuspid valve. All of them that you've heard about. If someone mentioned these valves, you will say, yes, I know because I'm a doctor. Now, what is important in their development? The answer is endocardial Cushing. Festus, how are they going to test me on this? How do you think you should be tested on this? They can give a patient that is having, they will just say the patient has, they notice when the patient is born, it has this also, like, let me say, aortic stenosis, or aortic regurgitation. Now, see, what do you think is the embryologic origin of this problem? The answer is endocardial Cushing. Relax, let me portray another question for you. Another question here is, they tell you that a pharmaceutical company develop a drug, that drug end up giving the patient maybe aortic stenosis or tricuspid atresia or something like that. Now, so which embryologic structure do you think the drug is actually affecting? The answer is endocardial Cushing. Okay, let me take the question further, because you need to be able to think like them for you to be able to answer most of their questions. They say this patient was exposed to a particular drug. The patient developed something like maybe aortic stenosis and the likes. Then I say, which other abnormality are you likely to see in that patient? You now be like, okay, if this thing is affecting the valve, it's affecting the endocardial Cushing, is there any other embryology process that endocardial Cushing is important in? You now be like, oh, septation. And I'll be like, if I check this patient is likely to have something related to abnormal septation of the chambers. Shikena. You just check through the option and pick that. You do not need to have seen that kind of question before you answer it. Very easy and straightforward. Then you come down to what we call aortic arc derivatives. Very beautiful note they've written for you here. What do you want to take into the exam? The reason why I need to go like this, I'm summarizing a lot of questions and giving you glimpse so that you'll be able to think wide and near, so that when we are done, you can go and carry questions and solve majority of them. Then there will also be a session where they are going to go through 1 or 2 questions for you, so that we'll be able to finish on time. Let's look at aortic arc derivatives. We have the first, we have the second. Then in my explanation, I will also be summarizing questions for you. Then we have the third, we have the fourth, we have the sixth. These are the aortic arc. Festus, do I need to cram all these? Sincerely speaking, you don't need to. Very easy and straightforward. First and second aortic arc, they hardly test them. The probability that in the exam you will be tested on these first two is very low. Very, very, very low. So if I were you, I will focus on third, the fourth, and the sixth. So what is happening to the third? Third correlated to the third letter of the alphabet. That is letter C. Which vessel do you want to remember that starts with letter C? Please don't mention that one you want to say coronary. No. So you'll be thinking more towards carotid artery. Carotid artery. So common carotid artery and the proximal part of the internal carotid artery. These are the two they are going to test in the exam. Now, how are they likely going to test it? They may say that, think about it. Anyhow you want to think about it. Let me give you a scenario. They can say that maybe a patient collapsed or they are trying to do CPR. A patient collapsed, they are trying to do CPR. The physician check for the peripheral pulses. They are not there. And the physician now moves to the rescuer moves to the carotid and check for the carotid pulse. And that one is not there also or something like that. Now be like, what is the embryologic origin of the carotid pulse, of the carotid artery that was checked or something like that? They can relate it to CPR. It just be like, oh, that is the third aortic arc, letter C. So under which condition do you think they can also test this? Let us assume that they say a patient developed a stroke. And that stroke that the patient developed actually came from the carotid artery, from the carotid artery atherosclerosis. Carotid artery atherosclerosis that was picked on the duplex ultrasound of the neck. And I'll say that, what is the embryologic origin of the carotid artery that that is having the lesion or something like that? You go for something like third aortic arc. Another likely question is, Mr. A and Mr. B, they are fighting. There is now a penetrating injury to the neck of Mr. A. So a vessel is damaged that actually supply, let me say, the central nervous system or something like that. Let me put it like that. They now say that what is the embryologic origin of that vessel? The answer is third carotid artery. Can you see how I'm thinking them out? So you also should think out. Because when you start thinking them out like that, USMLE now becomes the child's play. Because your ability to imagine things, when you are reading questions, you are not reading stuff. You are reading story that is clinically relevant. That's what will be going on. So that is for the third. Let's come to the fourth. For the fourth, if I ask how many limbs do we have, everyone will say fourth. Most especially for Festus and some people. Some people, we have 4 limbs. All right. So now, with respect to the fourth, to the limbs, on the left, when you look at the heart, look at the aorta. How does the aorta curve? Aorta curves to the left. You have this aortic arc that is now going like turn to the left and now start moving down. Thoracic aorta, then to the abdominal aorta. So that now eventually go down to supply the lower extremities and some other structures. So you can look at it like that. So on the left, fourth aortic arc is going to form aortic arc is going to form aortic arc. So note that. What of on the right? On the right, you make reference to which vessel do you think is going to supply the upper limb there? That is subclavian artery. So, and on the right, you say, yes, that will be right subclavian artery. So, on the right subclavian artery. On the left, aortic arc. So, I don't want you to be mixing right and left. That's why I related it to the way the aorta actually flows. It turns to the left, and you can use that for the fourth. That will be very easy and straightforward. What about the sixth? If you go into the exam and forget what we are going to say about the cyst, you must be a joker. And what is that? That is this proximal part of the pulmonary artery. That is on the left, and also the ductus arteriosus. So they love this ductus arteriosus a lot. Like, you don't want to joke with it. Ductus arteriosus. They will just say that this patient has this machine-like murmur, which what is the embryologic origin of the structure responsible for the machine-like murmur? Machine-like murmur, the structure that usually give birth to machine-like murmur is this ductus arteriosus or something like that, right? So when you read the questions, you are seeing something like maybe continuous murmur, machine-like murmur question, and they're asking about the embryologic origin. The answer is cyst aortic arc. So you don't want to forget this at all. Don't joke with it. No one will forgive you if you forget this. That's number one. They can also relate it to some congenital heart problem and just say that, okay, the ductus arteriosus is patent. What's the embryologic origin of this ductus arteriosus? The answer is cyst. So you don't want to forget this cyst and the ductus arteriosus. The last point under the ductus arteriosus is a nerve that is related to the ductus arteriosus, and that nerve is left recurrent laryngeal nerve. It loops round the ductus arteriosus. This is the nerve they will test with respect to this ductus arteriosus. So if I were you, I will not forget this. Left recurrent laryngeal nerve. They will ask it in the exam. Anyhow you can imagine it being tested, they will test it. They can test it anyhow. Just don't forget this left recurrent laryngeal nerve for USMLE step 1. What about the right recurrent laryngeal nerve? The right recurrent laryngeal nerve is related to the subclavian artery. So that one will be related to the fourth. If I ask all of us, on which or at what frequency, or what is the frequency with which you've heard about right recurrent laryngeal nerve and left recurrent laryngeal nerve in the medical practice? Everyone will shout it that I've had left recurrent laryngeal nerve more than the total number of times I've had right recurrent laryngeal nerve. What does that mean? It means that left is most likely going to be tested. Very simple and straightforward. Cyst, never forget that. Ductus arteriosus, never forget that. All right. So the kind of questions you can expect here, I've already summarized them for you. All right. So that we can finish on time. Let's come down to the heart embryology. The explanation I will launch will be related to how the questions will also be set that you want to note. I will talk about all of them and now narrow my explanation down to those ones you are expecting them to ask questions on in the exam. So this is, we have the atria, we have the ventricles. Everyone, let me represent them like this. Everyone will agree that this is actually what we have. So for the atria, we have what we call the trabeculated part. For the ventricles also, trabeculated parts. Very easy and straightforward. All right. So if you go to Nigeria or Africa, most of their roads there, they are very, very rough. So this trabeculated part portrays rough part of the heart. You can look at it like that. The kind of life you see, you see people living, you can peg them under primitive lives in a way. So because they lack development. So I will say that if the question asks about where do you think this rough part or the trabeculated part of the ventricles are coming from, I will be thinking towards primitive ventricle. Very easy and straightforward. Trabeculated part of the ventricles. If the question asks that, where do you think the trabeculated part of the atria is actually coming from, I will be thinking towards primitive atrium. Primitive, rough. You can look at it like that. What about the smooth part of the atria, the smooth part of the ventricles? All right. The smooth part of the ventricles, you can see this place, it looks bulbous. You can look at it like that if you wish. I'm only trying to have a way to portray the picture so that you will remember. So I will say that this smooth part is coming from bulbous cordis. All right, very easy and straightforward. The next place where you may want to do little assignment is with respect to the smooth part of the atria. All right. The smooth part of the left, this is the left atrium. The smooth part of the right, where is the smooth part of the left atrium coming from? Primitive pulmonary vein. First of all, you were mentioning rough, linking it to primitive. Yes, I need to explain it like that so that you will not forget where it's compared. This is primitive pulmonary vein. There is a condition we will be talking about later that is linked to this pulmonary vein, and that is the atrial fibrillation. So primitive pulmonary vein gives rise to the smooth part of the left atrium. Very easy and straightforward. All right. So what about the smooth part of the right atrium? Where is that one coming from? Right on of sinus venosus. How will I remember? Sinus venosus. Sinus venosus. Vein. Where do you think venous blood is going to empty into with respect to the heart? He said the right atrium. That one probably can help you to remember that. So, and this is right. So this will be right on of sinus venosus. Use that if you wish. All right. So let me clean this. We already have an idea of what is going on with the chambers. The other part of this art embryology that they can ask, we've already mentioned some of them. Truncus arteriosus. What is it going to give rise to? Everyone will shout, ascending aorta, pulmonary trunk. Very easy and straightforward. What about the endocardial cushion? We've already mentioned there. Atrial septum, membranous interventricular septum. These atrioventricular and semilunar valves. Very easy and straightforward. Those valves, then the septa, endocardial cushion. All right. The last but not the least here is about the superior vena cava and inferior vena cava. You can't enter into that exam and forget where superior vena cava is coming from, where inferior vena cava is coming from. No one will forgive you. No one will, because you can't predict. They love to ask questions around these two guys very well. No wonder, Festus, you wrote them out. Superior vena cava is actually formed from right common and anterior cardinal veins. I don't even know how to put it, but let me find a way around it to place it well for us. When you hear the word superior, you'll be like, sorry to use this, but like on top of something, like you can look at it like that. The way I'm looking at it is more or less like, why in Nigeria, like we have so many mountains, like Orioke, something like this, Orioke, something like that, and the like on top of where people used to go to pray. And I remember a particular denomination like CAC, like maybe CAC people, they have this Orioke, that, and the likes. So superior, like on top of something or upper part of something, common and anterior cardinal vein. Maybe that may help you in a way. All right, CAC, superior vena cava, superior CAC, common and anterior cardinal vein. All right, you can use that if you wish. If it doesn't make sense, you can discard that. What about the inferior vena cava? Where is it coming from? So this one, when you hear the word inferior, you will remember something like sub, like under, like beneath. You can look at it like that. Sub. Another one is posterior, then supra. Even supra, even if you look at supra, it look like upper, but just find a way around it. Just don't forget sub, then the posterior in a way. They are all related to inferior vena cava. So they will just give a question and tell you that where do you think, they will peg the question on. They might say they do one particular catheterization or something. Now see, the vessel that is catheterized here is probably maybe inferior vena cava. What is the embryologic origin of the vessel that was catheterized? A subcardinal vein, posterior cardinal vein, subcardinal vein and posterior cardinal vein. Any of them they will now go and put the order for superior vena cava there. Just don't forget CAC. Amidst the cardinal vein that form the inferior, you don't have CAC in it. So just this, you don't have anything like CAC there. So you have the sub, post, and supracardinal vein for the inferior vena cava. So apply that. Superior vena cava, to think around it, they might say that the vessel that empty into that normally drain the head and neck, that empty into the right atrium is actually affected, blah, 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 and the likes. Now, say, what's the embryologic origin of it? Okay, that's superior vena cava now, CAC. You just check the option and pick your common and anterior one. Very easy and straightforward. So you can complicate the matter the more. All right. Okay, I think you are going to okay. Look at this question. They give the story. They just say that a central line is placed to assess a structure embryologically derived from common cardinal vein. I just get into exam. I can't even remember again which of them. I'll just be like, this one has letter C in it. I remember that guy shouting CAC. More mountain, CAC, mountain, Orioke, Badura me, Orioke, something like that in Yoruba. So CAC, this is for superior now. You get it. Just be like, this is superior vena cava and the likes. That's what they are assessing here. So they will now give you a structure and just ask you that where do you think is the superior vena cava there? All right. So that's that about this area. So you don't need to sit down and cram this. You don't need it. You don't need this structure. Now you come down to this fetal circulation. What do you want to take into the exam here? Just relax. Let us show you. The most important thing you want to note here, number one, is the shunts you have with respect to the fetal circulation. Permit me to just reduce this so that you'll be able to see the totality of the diagram. So, the shunts that you have here, and you don't need to cram it, you just need to be able to think it through. Listen to the gist. This is the placenta. If you have any vessel that is draining blood away from any tissue or organ, you call that vessel a vein. If you have a vessel that is bringing blood to a tissue or an organ, you call that vessel an artery. All right, this is placenta. So if we have a vessel that is taking blood away from the placenta, what do you think we should call it? At least it should be a venous blood. So this is umbilical vein. In the exam, they may give you a diagram and ask you to identify it. So the one that is bringing blood to the placenta is actually the umbilical artery. Relax. Let me show you how the question can be tested at this level. They will give this diagram just like a short, they will just give you a cross section, a small portion of this diagram, like around this placenta and these two vessels. They will now label this that this is the placenta. They will now put an arrow here. They may put an arrow, they may not put an arrow. So let me assume that they just give you the oxygen saturation in this vessel. Let me draw what I'm trying to say so that you won't say that. They just give you this diagram in the exam. They now bring a vessel into it. They take a vessel out. This is the placenta. They now say that this one has the oxygen saturation in it is, let us say, 50%. The oxygen saturation here is 80%. Now, I want you to get the gist here. So, they will just say that they may label this one as X, they may label this one as Y. They just ask you that what is X, what is Y. If you are not very careful, you will miss that question. The umbilical vein drains blood away from the placenta and it carries highly oxygenated blood. So that is one thing. So while the umbilical artery supplies blood into the placenta and it carries deoxygenated blood. So they will just say X is umbilical vein, Y is umbilical artery, X is umbilical artery, Y is umbilical. You just give it a table and you choose your answer. So you don't want to forget this at all. So with respect to the placenta, the vessel that is draining blood away from it is the umbilical vein and it carries highly oxygenated blood. So it shows that when the blood comes to the placenta, it's picking oxygen. So when it's leaving, it's now going to take the oxygen to the baby. So this one is umbilical artery. It carries deoxygenated blood. Number one, concept number. Don't forget that. All right. So now, at this level, here, if you look at it, this is inferior vena cava, umbilical vein. This is a vein. This is a vein. You have blood leaving this umbilical vein coming to the inferior vena cava through a dot that is connecting these two veins. Which name do you think you want to call it? Yes, that thing you are thinking about is correct, and that is ductus venosus. A dot that is connecting two veins. And that's how they come about this name. All right, so which means that proximal to where this dot is emptying into the inferior vena cava, when you check the oxygen saturation here, is going to rise because highly oxygenated blood has emptied into it or has been shunted into it. Never forget that. So the oxygen saturation here you will have is going to be high. They test this in a way. You might not just have seen some question on it, but please, everything we are going to be telling you, note them. All right. Now, when this blood eventually enter into the heart, where will it go? Question number 2. The blood, when it is empty, the blood from the inferior vena cava, when it's emptied into the heart, it goes to the left atrium, from the right atrium to the left atrium. So, majority of them, when they come to the right atrium here, they just move to the left atrium. Through what? Through the foramen ovale. So, it's more or less like the blood is coming like this. Note it. It's just going to go like this. Sorry. It's coming like this. It's now going up like this, like into the left atrium. All right. So that's that. Expect question on that. If not question, they can paint a scenario on that. Where does it go to? So from inferior to the right atrium to the left atrium. Please note it very well. What of from the superior vena cava? Where does the blood go to? It just comes down. Can you see? From the right atrium to the right ventricle. So if you look at this, we have like a cross here. Let me show you something like this. This one goes like this. This one comes down like this, like a cross. You must note this. It's not maybe, like note it very well. They can portray a question on that for you. You just see that superior vena cava, blood coming from there. How does it move? Where does it go to? Right atrium to the right ventricle. What of the one from inferior vena cava? Right atrium to the left atrium. Can you see? If you are not very careful, you may go and pick right atrium to the right ventricle. That would be wrong. Majority of them go from right atrium to the left atrium. Through what? Foramen ovale. So that is another important point. So which other one do you want to note? When blood comes into the right ventricle, where does it go? The same thing you are thinking about. It will go through the pulmonary, this pulmonary trunk, and comes to the pulmonary artery here. All right. So from the pulmonary artery, it's going to be shunted to the aorta. You want to note that. What is going to, through which vessel is it going to be shunted? Ductus arteriosus. That's another shunt you want to note. So most of the time, when they set question here, it's a battle of oxygen saturation. They will just be putting oxygen saturation. In the exam, they may put this place as 99%, and put the one for the inferior vena cava 70%. They will now say that, what do you think is going to be the oxygen saturation of the blood in the inferior vena cava just before it empty into the right atrium? If you look at that question, A, 70%, B, 99%, C, 80%. Don't forget that if you remember that, ductus venosus empty or takes highly oxygenated blood from the umbilical vein into the inferior vena cava and empty. So the oxygen saturation here is going to rise. So the answer must definitely be more than 70%, but less than 99%. So that's just what you are going to be doing there. That is the essence of the shunt, and that is how most of the time they love to test it in the exam. Just for you to note how those shunting occur. The same thing for the pulmonary artery and the aorta. In the pulmonary artery, don't forget that the oxygenated blood is what you have here. And in the aorta, you have the oxygenated blood. So if the oxygenated blood is being emptied into the aorta here, the kind of oxygenation you are going to be picking here around the maybe thoracic aorta or something like that, or distal part of the aorta, is going to be lower. Like the oxygen saturation there is going to be lower just from that mixing. Please just try to notice so that don't prolong the matter for you there. All right, so those are the shunting you want to note. The next important point is this ductus arteriosus. What do you think is keeping it open? That's the next question. This ductus arteriosus, what do you think is keeping it open? The answer is prostaglandin E1, E2. So in the exam, you might check the options for E1, E2, they are not there. Just pick prostaglandin E, Shikena. Prostaglandin E. So that is that. So prostaglandin E will keep the ductus arteriosus open. Never forget that. Now, where do you think these prostaglandins are coming from?
Most of us can see your screen, Dr. Festus.
So when the baby is now born, placenta is removed. So this prostaglandin level in the patient, in the baby's blood, will fall. By the time it falls, prostaglandin is not available again to keep it open. Then it will start closing up. It will start closing up. Are you seeing the screen? Hope we are seeing the screen. Can you hear me?
No.
Huh?
Yes.
All right.
Yes.
Okay. So please note that the source of prostaglandin opening it is the placenta. Fetal-postnatal derivative. What do you want to take into the exam here? Very simple concept. Look at these structures. Their own duty is to mention them. Your own is to identify the postnatal derivative of them, and I will tell you the common ones they test. We have this ductus arteriosus, ductus venosus. They just give rise to the ligamentum. Arteriosus will be arteriosum. For the ductus venosus, ligamentum venosum. Very easy and straightforward. So remember the nerve that wind round the ductus arteriosus. Left. Correct laryngeal nerve. I arrowed it again because you will be tested on it. That's that. What about the foramen ovale? Postnatal derivative is going to become fossa ovalis. Ovale, ovas, or ovalis. So don't mind my pronunciation of V, just note the postnatal derivative. I have these two structures in the box, in this rectangular stuff. Festus, why do you put them? Because these are the most tested ones in the exam. We have the allantois, we have the umbilical artery. Allantois can easily give rise to urachus. Now, from this urachus, the postnatal derivative of it is median umbilical ligament. For the umbilical artery, it's going to give rise to medial umbilical ligament. They sound and look alike. So that's why they test it very well, because in fact, you can easily miss it if you are not very careful. They will just say that this allantois, what do you think is going to give rise to in the postnatal period or something like that? They will ask the option A, medial, option B, median. So your duty is just to know which one has letter A-N in it, which one has letter A-L in it, and that's all. So be very careful so that you don't go, if you can look at letter N, I think letter N is better. Which of these two structures, these two, allantois and umbilical, which of them has letter N? The one that has letter N is the one you give median to. The other one you will give medial to. Because if you want to use AL, AL is in umbilical, AL is in allantois. So just use letter N, this letter N, use it. The one that has N, median. The one that has the other one will become medial. How do they normally portray question on this urachus? Urachus usually connect the bladder to the what do we call it? Umbilicus. So bladder should contain urine, right? You say yes, that's good. So they will just say that the baby is born and they notice a clear fluid around the umbilicus. Where do you think the fluid is coming from? You will start thinking towards patency of the urachus. Urachus is not closed up. That's all. Very easy and straightforward. So it shows that the urachus is not closed up. It's not obliterated. So the answer is urachus. If you check the options, you don't see urachus there, you go for allantois. So don't forget, a baby that is draining urine through the umbilicus. There is another one we'll be looking at later. All right, so that's that. Umbilical vein, ligamentum teres hepatis, so which is contained in falciform ligament with respect to the liver. And that's that about the embryology. All right. I hope we are awake. You can sip something now. And for those that have been sipping something even before we ask you to do so,
Water now, everyone is sipping.
Sip more. Sip more. Keep sipping. All right, so that's just the basic things you just want to revise. As I told you, most of all what we have shown you there, it's not that maybe they are the ones, all of them they will test. Majority of them, you may not even see singular question like this in cardiac embryology. That's why you just want to pick the point. Okay, if after I see something like this, I will just go for this. If you read a question now that is related to cardiac embryology, you can basically look at it and be like, I sure hope this question is not about the paradoxical emboli. I hope it's not about what do you call endocardial Cushing. I hope it's not about this, about that. All those ones, basic points. You just quickly look at it. You can even make a guess about it and be like, I'm likely going to just go for A based on the story that surrounds it. So you don't need to sit down and now start cramming unnecessary jargons. You will be giving yourself unnecessary headache that has not been classified. You just say unclassified headache or USMLE related headache. All right, so keep it easy, simple, and straightforward. So just don't be too bothered. So let's continue. Look at the anatomy briefly. We have the heart anatomy. What do you want to take into the exam? Very simple concept. Number one, you must never enter the exam without understanding this diagram. Hey, you must never. Don't joke with it. You must never enter into the exam not understanding how you will be applying diagram B. That's like you must be joking if you don't understand how you'll be applying it. Then some other point I'm going to bring out here. So number one, what is the most posterior part of the heart? That's the question. The answer is left atrium. If they wake you up from sleep, you shout left atrium. God intentionally left it at the back. Left atrium, the most posterior part of the heart. All right. The most anterior part of the heart, right ventricle. Right ventricle. So, what are those things that can happen to a patient that can affect the anterior part of the heart? Trauma, road traffic accident, penetrating injury to the anterior part of the heart. Now, see which structure will be affected? Right ventricle. And that's how they will test it. That's how they love to test the right ventricle a lot. Penetrating injury to the anterior part of the heart. Which part of the chambers of the heart will be affected? The answer is right ventricle. It is the most commonly injured part of the heart in trauma. This is what they will ask. All right. So if you bring they might say a wife maybe stabbed the husband by the chest. So this is the knife. The knife now, let me put it in red. The knife now moves into the and penetrates it like the perpendicularly. So now the which structure will be affected? Your answer is just always going to be right ventricle. But if the question says that object, knife also, is directed laterally, it's not perpendicular. So if it's directed like this, it's likely going to be the lung. So you must be able to differentiate when lung will be affected, when right ventricle will be affected. So when you see the trauma question, they say something penetrated. Your duty is to check, is it perpendicular? If it is perpendicular, the answer is right ventricle. If they say it's directed laterally, your answer is most likely going to be the lung parenchyma. Very easy and straightforward. What about the posterior part of the heart? Anything that can make the left atrium to enlarge. There are some structures that are around the left atrium. The left atrium will be compressing on them. A very good example is esophagus. So, under which condition do you think the left atrium will enlarge? The same thing you are thinking about. Mitral valve stenosis. Mitral stenosis. So if there is mitral stenosis, blood cannot easily leave the left atrium into the left ventricle. Blood will now be accumulating. The left atrium will now start ballooning out, enlarging, and you start compressing on the esophagus, and the patient will be complaining of dysphagia. Very easy and straightforward. Is there any other structure that can be affected? Left recurrent laryngeal nerve. So left recurrent laryngeal nerve also can be compressed on, or there can be a pressure on it, and the patient will have this hoarseness of voice. So you put all these things together in Ortner syndrome. USMLE will never test you on syndrome. It's not a syndromic exam, so they won't write syndrome in the exam. They will just say that this patient has left atrial enlargement. Which of the following are you also likely to see in this patient? Once you see left atrial enlargement, the answer is dysphagia. You say the patient can have dysphagia, or hoarseness of voice. They just put in, they just be like, oh, the condition they are testing is Ortner syndrome, but they are not putting Ortner there. They are just, what are you like? What do you think this patient is also likely to develop, or are you likely to see in this patient? You just be thinking towards something related to esophagus, something related to left recurrent laryngeal nerve. Very easy and straightforward. So that's the first aspect and this diagram. So know the right ventricle, know the left atrium. So what about this other diagram? All right. Most of the time, I want you to look at this. Most of the time, with respect to this, they will just put a lead, the same lead, They just place it somewhere here and just say that, where do you think the lead is located, or a particular object? It can be anyone they like. Shall put it somewhere. So let me assume that there is a lead here. They just put it here. They now say that, where do you think that lead is located? So, or they put the lead here, or they put it here, or they put it here. So in the exam, don't give yourself headache. Just look at it and be like, the upper part here, look at this bulbous part of the heart. Can you see? Just divide it into two. Use your eyes to divide it into two. You won't be wrong. So now, slash it again like this. So don't mind me. So if the lead is located in this quadrant, you say right atrium. If the lead is more in this area, you say right ventricle. If it's more here, left atrium. If it's here, you say left ventricle. Very easy and straightforward. So nothing much. All right. So left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior cardiac surface. So when you look at this cardiac surface here, so left ventricle constitutes majority of this inferior part. Right ventricle is just the other part. All right. That's 1/3. Right ventricle, 1/3. Left ventricle, 2/3. Don't forget that. And that's all about this area. What about the pericardium? What are they going to be testing here? The other part here that I left, this upper part of this diagram that I left, nothing much on them. There are some conditions I'll be making reference to later with respect to the mediastinum, but don't worry, we'll get there. Look at this pericardium. What are you expecting them to test you on here? Two conditions, actually. It can be related to pericardial effusion. The next important point is pericarditis and also the nerve innervation to the pericardium. So mostly the nerve innervation to the pericardium. the nerve innervation to the pericardium. So which nerve supply the pericardium? And that is phrenic nerve. Shikina. Phrenic nerve. A patient with pericarditis, blah, 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 is having pain that is referred to the neck, arm, blah, 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 and the like. Oh, this patient is having pain. They now say, which nerve mediate that pain? So your answer is going to be phrenic nerve. Chicken. This is what they will be asking. Please let us mute our mics once you know that you are in a noisy place. Thank you. This patient has fluid in the pericardium, blah, 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 and the patient is having pain. You're having pain relating to this place, blah, blah. Which nerve is carrying that pain? You go for phrenic nerve. So this is what they are most likely going to test. So if you're not going to the exam, you now forget phrenic nerve. You say because when you were solving questions, you didn't see it. You now get into it and you're like, they didn't bring you what? They didn't bring this. It's because you didn't study what you are supposed to study. So what else do you think they can ask you on pericardium, if not really this one? Basic points. What of coronary blood supply? We are going to look at it in a very simple way. So nothing much here. Look at it. Imagine the heart is before you. You have the anterior part of the heart. You have the posterior part of the heart. We have the inferior part of the heart. And God is so wonderful, also put some nodes in the heart. We also have lateral part of the heart. But let's look at anterior, posterior, inferior. So which vessel is going to supply the anterior part of the heart? So your answer most of the time is going to be this lad, left anterior. If you look at the name, anterior comes out of it. Left anterior descending artery. Left anterior descending artery. So if they give a question where the patient is having myocardial infarction and you now look at it, you realize that most of the anterior leads, they are actually showing ST segment elevation. The question is, which vessel is affected? Just go for LAD, that's all. Left anterior, at least you can see anterior is part of the name. So I do not know why you will go for another name. So left anterior part of the heart. So is there any other portion, any other point you want to note here? We talk about interventricular septum the other time. You say yes. First, let us divide it into two. The anterior part of it, the posterior part of it. It's more or less like a wall. Let's divide it that the anterior portion of that interventricular septum and also posterior part of it. So the anterior part of it also will be supplied by LAD. Left anterior, you get descending artery. So very easy and straightforward. If they give us another question again and they tell us that they notice that maybe, though it's not common, I will tell you why. They notice that the anterolateral portion of the papillary muscle is one of the structures that help in the proper maintenance of the mitral valve. Those valves, basically, anyways. Anterolateral portion of the papillary muscle is affected. You just look at the name. Anterior is also part of that name, LAD. Though anterolateral papillary muscle has dual blood supply. Anterolateral papillary muscle has dual blood supply. One of them is LAD. The second one is this left, what do we call it? The lateral circumflex artery, or left circumflex artery rather. All right, those are the two that supply this anterolateral. But from the name antero, you already know that LAD is going to be part of it. So very easy. Just look at the name that is given to you in the exam, or look at the portion which lead. Once the lead contains anterior, go for LAD. It's just as easy as that. What of this posterior? Posterior descending artery. We'll be thinking towards anything posterior. You look at the interventricular septum. they are mentioning in the question that posterior part of the interventricular septum, peak PDA. They are talking about posterior part of the heart, peak PDA. They also mention something like posteromedial. I can see posterior in the name, peak PDA. Is that not easy enough? Don't give yourself headache. All this other and this one, just ignore them. Make it easy for yourself, because in the exam, your brain will not be able to think in a complex way. Your brain is going to think simply, and you need that. So PDA, just pick that. Posteromedial part of the papillary muscle is supplied by PDA. And this posteromedial part of the papillary muscle has only one single blood supply, which is PDA. Now, let me tie the two of them together. You cannot go into the exam and forget papillary muscle. It is the most important structure here that you will be using to answer question for the coronary blood supply. So, I've mentioned two things about the papillary muscle, anterolateral and posteromedial. I used to call it P-mal. P-mal. Posteromedial, anterolateral. They asked me which was the blood supply to the posteromedial, PDA. Blood supply to the anterolateral, I will say LAD and LCX, left circumflex artery. LCX. LAD and LCX. Can you see? So it shows that if anything happens to LAD, this patient, nothing will happen to the anterolateral part of the papillary muscle, because the second one, this left circumflex artery, will continue the supply. If anything happens to the left circumflex, nothing will happen to the AL, that is this anterolateral, because LAD will take over the supply. However, for the posteromedial, if anything should happen to the PDA, the posteromedial will start malfunctioning, and the patient will develop what you call mitral regurgitation. Very easy and straightforward. All right. So that's for the posterior. Come down to the right coronary artery. How will you know the right coronary artery is affected? Right coronary artery supply the nodes, SA node, FE node. They will just give you a question of a patient has MI. You don't know the vessel that is affected. You now start seeing that this patient is in shock. However, you cannot see anything like tachycardia. When there is shock, sympathetic nervous system should come into play and give the patient tachycardia. This patient has MI, is in shock, and I'll check the question. The pulse rate is low. Until proven otherwise, right coronary artery is what is affected. It shows that infarction has also affected the nodes. The nodes. So because they are affected, SA node also is not giving out the information. AV node is also misbehaving. So the pulse you will see in the patient is going to reduce. Very easy and simple concept. Never forget this. All right. There is a question they can also ask, even though it's not in the first aid. I added it. The lateral portion of the right ventricle. The lateral portion of the right ventricle, what supplies it? So, right coronary artery. Please just don't forget it. I want you to note it very well. Supplies the, most especially the marginal artery anyway. Marginal artery, this marginal artery, it supplies the lateral portion of the right ventricle. Please note it very, very well. Marginal artery, very, very well. Please note it. So that is about this blood supply. If anyone asks you a question on this vessel and you are saying nonsense, they should crucify you head down. So don't forget them. Anterior, posterior, the right coronary artery. That's for the nodes and the inferior part of the heart. All right. So let us look at what we call dominance. So in the exam, they will just ask you that, is this patient right dominant? Is this patient circulation right dominant or left dominant? What is the dominant asking? I'll show you a sample of how you'll be seeing the question here, because it's very logical. So the question on dominance is asking which vessel is supplying PDA. PDA is like their baby. Who is taking care of PDA between you, these two parents? Who are those parents? Right coronary artery and this left circumflex artery. Who is taking care of this baby? This baby is posterior descending artery. Who is taking care of it? So if it is the right coronary artery, you call it right dominant. If it is the left circumflex, you call it left dominant. Now relax. I will slow down here so that you get the gist here. They give me a question. And in that question, I noticed that from the nature of the question, the patient has MI. And that MI is affecting the inferior part of the heart. I'm already thinking that this is right coronary artery that is affected here. All right. If it's right coronary artery, I will just be like, because the ECG they give me, I'm seeing ST segment elevation in the lead 2, lead 3, and the AVF. I used to say 2, 3, my foot. Lead 2, lead 3, and the AVF. That's what I'm saying. So it shows that right coronary artery is affected. For me to determine the dominance of that patient, the next thing I will trace in that question is this patient also having mitral regurgitation? If I check through the question, I can't see anything that is related to the mitral valve. Every other examination is normal in that patient. I will be thinking more towards something like left dominant. It showed that PDA does not come from RCA. RCA is affected, and I can't see any evidence that PDA is affected. Definitely PDA is not from RCA. If the question says this patient has inferior MI, and I check through that question, the patient is also having holosystolic murmur that is radiating to the apex. I'm already thinking towards mitral regurgitation. The 2, 3, my foot, I'm seeing mitral regurgitation. What is going on? It shows that this patient is right dominant. The patient is having right coronary artery being affected, and also PDA is affected because PDA is coming from that right coronary artery. Shikina. That's how I determine my dominance. So if I check through the question, I can't see anything affecting the PDA. I can't see holosystolic murmur. I can't see anything like mitral valve regurg. I will be thinking more towards something like left circumflex artery. So this is left dominant. Very simple and straightforward. I'll show you a sample. Codominant is when the PDA is arising from both of them. Codominant. All right. So that's that about that. Let me show you 1 or 2 questions here for you to understand it better. So don't go and waste time in the exam. So look at this. 51, I have not mentioned one thing, and that is the lateral portion, lateral part of the, what do we call it? Lateral part of the heart. That's the part of the heart that is like more or less like closer to your left upper limb. You can look at it like that. So that what is supplying it is this left circumflex. So that's why, if for simplicity's sake, if you can look at it as lateral circumflex, if that will help you, you get but left circumflex artery. So that's the lateral portion. So when we look at the ECG given in the exam, you just want to check which part of the ECG is affected. So look at this question. 51-year-old man is brought to the emergency department due to chest tightness that started 30 minutes prior to arrival. So his chest discomfort is associated with shortness of breath and nausea. The patient was shoveling snow off his driveway when his symptoms began. He has a history of hypertension, type 2 DM. Initial ECG shows ST elevation in lead 1 and AVL. These are lateral leads. That's where they are seeing the ST elevation. And they see cardiac enzymes are elevated. 1. This is myocardial infarction until proven otherwise. I will show you how you will be identifying myocardial infarction in the exam. So 1, cardiac enzymes, they are elevated. Number 1. Number 2, the ECG they are seeing is not changing. They are still seeing ST segment elevation and is there. So if it's there and they check it again, the question says it's there, it disappear, it's there, it disappear. You won't be thinking towards myocardial infarction. You will be thinking towards angina, vasospastic angina. I will show you all those stuff. Just relax. So definitely this is more or less like MI. Then the duration that the patient has been having pain. This is not angina because this is more than 10 minutes that the patient has been having it. If it's just within 2 to 10 minutes, we'll be thinking more towards angina. All right. So this is myocardial infarction based on the duration, based on the cardiac enzymes that are elevated, based on these ECG findings. They now say emergent cardiac catheterization in this patient will most likely show what? Occlusion of which vessel? I will just quickly come here and check where are you seeing ECG changes? You say lead 1 and AV L. L, you can look at L as lateral. Once I see this, I know it's lateral part of the heart that is affected. The vessel there is left circumflex artery. Shaken up. So look at another question here. 78-year-old woman is hospitalized due to acute MI. The patient had been having intermittent chest pain for 3 days and came to the hospital when the pain became unremitting. She has type 2 DM, but her medical follow-up has been poor. On the 3rd day of hospitalization, the patient has sudden onset shortness of breath due to pulmonary edema. Echo confirmed severe mitral regurg. Wow. The patient has acute MI and the patient has severe mitral regurg. They now say that she is taken immediately to surgery, which revealed rupture of posteromedial papillary muscle. I just see posteromedial papillary muscle is ruptured. The question is now asking, this patient finding typically suggests compromised blood flow through which of the following coronary artery? Posteromedial, I can say posterior in it, posterior descending artery. You can see, let me show you one question on dominance. Look at this question. So you don't mind, I always show you the answer because this is not about, you are only learning. So you are not putting yourself under any, just for you to have an idea of how the questions will come. So that's the whole essence. And for you to get the explanation behind them and move on. All right. So look at this. A 56-year-old man is brought to the emergency department due to sudden onset severe chest pain. Blood pressure is 88/56 and pulse is 83. On physical examination, the patient is in moderate distress. The jugular veins are distended. All right. This patient has sudden onset severe chest pain. Blood pressure, look at the blood pressure. I want you to note it down. Blood pressure is low, 88/56. This patient is in shock. He's in shock. Most likely cardiogenic shock, but I don't know yet. And now look at the pulse. The pulse is 83. This patient is in shock and the pulse rate does not increase, does not give me the vibe that this patient is in shock. Because with shock, sympathetic nervous system is supposed to be activated and that should make the patient to have tachycardia. This is not tachycardia. So what is going on? On physical examination, the patient is in moderate distress. The jugular veins are distended, which is telling me that there is a problem with the heart. The heart is not contracting. That is why blood is entering into the heart but not leaving. Then the jugular vein will now distend out. ECG is now showing evidence of ST segment elevation, myocardial infarction. So this patient has MI, STEMI. The next thing is bedside echo revealed contractile dysfunction. So the heart is no longer contracting. Definitely something is wrong with the blood supply to the muscle of the heart. Of a large portion of the right ventricle and normal function of the entire left ventricle, consistent with MI involving only the right ventricle. They now do percutaneous coronary intervention. We call it PCI. We normally do PCI with coronary angiography just for you to know which vessel is affected so that you will know the vessel you are sorting out. That is what the coronary angiography means. So you just put their contrast or whatsoever they want to put it, just for you to see which vessel is affected. It's performed and shows thrombotic occlusion affecting one of the major coronary arteries. No other significant atherosclerotic lesion are identified. Which of the following is the most likely explanation? That's the question they're asking here. Right ventricle is affected. Definitely, this patient has problem with right coronary artery. Shikena. But what is the coronary artery dominance here? How will I know? Can I see anything that is related to mitral valve in this question? I already know that right coronary artery is affected from this question. You can see the hypotension. You can see pulse is not increasing because SA node is also supplied by the right coronary artery. So if something happens to the right coronary artery, SA node also will be affected, AV node will be affected. That's why the pulse is not increasing. All right. So I already know the vessel that is affected here, coupled with the part of the heart that is affected, right ventricle. So right coronary artery. Now, what is the coronary artery dominance here? Check. Can I see anything related to mitral valve in the question? Just check that. Don't give yourself any headache. I can't see anything related to mitral valve here. Definitely, PDA is not coming from right coronary artery. It's likely coming from left circumflex artery. So therefore, this patient in this question is left dominant. Chicken out. Very easy and straightforward. So you can go and carry more questions and just try to attempt them. And that is all about the anatomy of the heart. All right. That's all about the anatomy of the heart. Basically, if you look at it, that's actually what you have to take into the exam. You don't need too much information. So keep it simple in your head or heads. When you get into the exam, you will just be overthinking. And as I said earlier, more than 90% of whatsoever we look at in the anatomy, more than 90% of them will not even be tested at all. So, but you can't predict which one will be tested. Then the patient we are going to be seeing, you cannot really say that this is this one that the patient is going to, you will use to sort the patient out. So that's why you can just pick one or 2 points in each of them. Do you get me? So that at least you have something at your fingertip. If you do not think simply, a day or 2 or 3 days towards the exam, you will start forgetting things. You will now be having palpitation, you will be having tremor, you will be having you will be feeling quite uncomfortable. You may not even be able to sleep, your head is pounding and the likes. So inside the examination, the question is there, this person is shouting, I can't see any question, and they are like, it's right before you. I'm not seeing the question. So all because the information they are just evaporating. So many people they've called like that. It just be like, oh, Festus, this is how I'm feeling and the likes. You don't need that. Just keep it very simple. Even if your friends they are trying to move unnecessary stuff for you, that I saw this in this also question, and you look at it, it's not really in the first aid. So just put it aside and revise, because you can't go into the exam with what is in the first aid and you claim that you did not prepare. That's wrong. You can't know all those basic points and claim that someone will now say that you didn't prepare enough. You've actually prepared. The problem with so many people is that they are using so many materials. This one will say this one will say this one will say that. The only material that has been quite consistent over the time is still the first aid. So what is in first aid 2020 is still the same thing you'll be seeing in the first aid 2024. They may just do 1 or 2 rearrangements. So everyone, keep it simple. Look at it simply the way we are looking at them, and you'll be fine. Let's look at what is going on in physiology. I hope you can sip something again now. Sip something. And if you like, finish 2-3 bottles of NSC in the name of you are sipping something. You will slip off. All right. That you want to take into the exam. Let's look at the physiology. For the physiology, we have what we call the cardiac output variables. There is no one here that will say I've never heard about cardiac output before. Everyone has heard about it at one point in time. So we now want to tell you more about that thing you've heard about. So the first variable we'll look at is stroke volume. When the heart pumps, that volume that leaves the heart, that with per beating, is what you call the stroke volume. So what do you think can make the stroke volume to go up? Let that beating be more aggressive. Let it be more powerful. So if you increase contractility, heart will contract more and push out more blood. So increase in contractility will help. The blood that the heart is pumping out, maybe is the same blood that is loaded on the heart. If we load more, the heart will push more out. So increase in preload. Afterload is more or less like resistance to the outflow. I've loaded the heart. I expect the heart to pump the blood out, but some stuffs are sitting at the entrance to prevent the blood from leaving the heart easily. You can look at that as afterload. So if I can reduce those obstruction, more blood will leave the heart. Therefore, reduction in afterload will increase the stroke volume. So there are things you can relate it to your room and entrance. Do you get me? You can relate it to pure water. Pure water, when you, let me enlarge this thing back. Sorry. You can relate it to pure water when you just try to tear the tip and you are trying to just press the water out. So the more you press it, the more it goes out, or the more volume will go out per time. So if it has a lot in it, more will also go out. If you tear it very well, more will also go out. That's the afterload. Do you get it? So you tear it very well, more will go out. You can look at it like that if you wish. So that is about these three. I call these three CAP, and we are going to be looking at CAP from now on. Contractility, afterload, preload. So when I say CAP the heart, you shout contractility, afterload, and preload. All right. There are some entity they can bring out in the question again. So you call it work done. Work done. So stroke work is actually the work done by the ventricle to eject the stroke volume. The way the heart is working to push out those blood. All right. So the work done is definitely going to look at the formula for work when you were in secondary school. It's equal to pressure multiplied by volume. Pressure multiplied by volume. So that is work. Work is equal to pressure multiplied by volume. So if I load more blood into the heart will need to do more work to push them out. That is this volume. If there are obstruction, after load is very high, there are obstruction. So, or the mean arterial blood pressure is high. This pressure is high, mean arterial blood pressure. The heart will also be doing more work done. No wonder hypertension, if the care is not taken, can lead to heart failure. Because when you do work after a while, you will get tired. If the heart is pumping against high blood pressure, so after a while, the heart will start failing small. So work done is equal to pressure multiplied by volume. This will help you to understand what is going on. A failing heart has reduced stroke volume because it can push it out. So that's that about stroke volume. So you don't want to forget contractility, preload, and afterload. Now, the next place where USMLE love to hide a lot is what you call contractility. Contractility, how the heart is contracting. Like, you can't go into exam and escape this in cardiac physiology. It's a sin not forgivable under the USMLE law. It's not possible. Even if you beg for forgiveness, they won't forgive you. So what is going on in contractility? Look at it. There is a particular ion that we need for contractility. And that ion, you call it calcium. Lovely. So when we are talking about contractility of the heart, the ion that should come to your head is calcium. I need calcium. I need calcium. I need calcium. All right. So if that is the case, we are going to divide this into two categories. A situation where we load calcium, we store calcium, and a situation where we release calcium. Because these are the categories of questions you are going to be having with respect to the contractility here. So we need to load calcium to store calcium so that when we need that calcium to cause contraction, we have enough calcium that can be released. But the more you save, the more you release. So how does the heart store calcium? So the heart is going to store calcium inside a particular organelle You call it sarcoplasmic reticulum. Sarcoplasmic reticulum. That is where the heart is going to store the calcium. So what is important in storage of the calcium? The channel that you need to store the calcium is actually this calcium ATPase. This calcium ATPase. Never forget this calcium ATPase at all. So if I need calcium ATPase to store calcium in sarcoplasmic reticulum, there must be a way to activate it. God is so powerful. God looks at this calcium ATPase and be like, if I leave you to be doing what you are meant to do, you are going to keep on storing calcium, and you will not know when to stop. God now did something. God linked a particular protein with this calcium ATPase. So, and that protein is what you call phospholamban. Phospholamban. I don't think phospholamban should be a big name that will be confusing you. So phospholamban will hold this calcium ATPase and prevent calcium from moving through it into the sarcoplasmic reticulum. Look at it. Imagine someone is beside you. That person is calcium ATPase. You are the phospholamban. You are now holding that person that don't do what you are supposed to do. That person will not do it. God now put a system in the woman's body in such a way that when this calcium ATPase needs to be active, we need to find a way to distract phospholamban. Phospholamban, you are holding calcium ATPase. You say, yes. Please, can you help me hold this phosphate? So we need a protein that will be giving phospholamban phosphates. When phospholamban is giving phosphate, it's going to release this calcium ATPase. Calcium ATPase will now become active. It will now start bringing in calcium into the sarcoplasmic reticulum. Phospholamban, when you are lambasting someone, if I face you now, I'm lambasting you, how will you feel? Whatever you are doing, you are going to leave it. You will focus, you'll be distracted. That's what phospholamban is doing. So we need to give phospholamban something that is going to distract it away from preventing calcium ATPase from being active. And that thing we will give it is phosphate. You can't enter into the exam and forget this calcium ATPase. So if you look at this calcium ATPase, it is linked to sarcoplasmic reticulum, right? You say, yes, that's good. Let us give it a well-decorated name. And the name is SACA. Sarcoplasmic reticulum associated calcium ATPase. Something like that. So SACA. S-E-R-C-A. SACA. So please don't forget that. So that's SACA. That's how we store calcium inside the sarcoplasmic reticulum. So another point you don't want to forget is, how do we now release calcium out? Calcium has been stored. How do we release it out? We now need a channel too that will allow calcium to move out. So the first channel we are going to talk about is what we call calcium channel. That calcium channel is just on the normal membrane. It's on normal membrane of the cardiac myocyte. So when calcium is supposed to be released, let me draw it for you. This is the normal membrane. This is the sac here that calcium has been loaded inside. Calcium has been loaded inside. So we now have calcium channel here. Because they will test this channel in the exam. They will test them. Calcium will now enter here. When the calcium enter, the calcium from here inside the cytosol, the calcium from inside the cytosol here will enter into the sarcoplasmic reticulum and lure the calcium that has been stored to be released. You call it calcium-induced calcium release. Calcium needs to enter and lure it out. This is one of the ways by which calcium is released. So you must never and never forget this. So when calcium is released into the cytosol, calcium can now start causing the contraction. So they will test this channel in the exam, the calcium channel on the membrane of the myocytes. And don't forget, what is helping to load calcium inside the sarcoplasmic reticulum is SACA. You forget SACA, you are in trouble. Top. Not the SACA that is playing football. This is SACA. All right. So please don't forget this too. Calcium induce calcium release. Never forget this. Calcium will enter into the cytosol, and from here is going to induce the release of calcium from the sarcoplasmic reticulum. Shikina. Calcium channel. The calcium channel you have on this sarcoplasmic reticulum is SACA. Never forget it. All right, let me clean this. What else, Festus? Are they likely going to ask us? And that is another concept. The concept is about this statement. I just want you, if by cramming you will cram it or just note it, that anytime there is increase in intracellular sodium, there will be equivalent increase in intracellular calcium. So you can look at it like increase in intracellular sodium is equivalent to increase in intracellular calcium. So how am I going to apply this? They will just give you a scenario where there is increase in sodium within the cardiac myocytes. Then ask you, what do you think the patient will have? There will be increased contractility. It's a statement, like you just want to put it at the back of your mind. Increase in intracellular sodium is equivalent to increase in intracellular calcium. Anyhow, the question comes and you notice that there will be sodium channel is blocked here. Sodium will accumulate, blah, 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 inside this cell. Because if I'm blocking the sodium moving out of the cell, then definitely there will be a ripple effect to the calcium channel. I don't want to be going into the detail of it. So calcium will now stay inside the cell and cause increase in contractility. Never forget this. How are they now going to, what are they going to link this to? Number one is this extracellular sodium. Extracellular sodium. We have extracellular, intracellular. The point Festus gave you is intracellular sodium. Increase in intracellular sodium will cause increase in intracellular calcium. The question now says that there is reduction in extracellular sodium. If extra is low, then intra is high. Therefore, that patient will have increase in contractility. Shikina. Just remember this statement, write it down, so you can now be doing qualitative reasoning with it. So if the question says that extracellular sodium is low, definitely intracellular will be high. If that is the case, intracellular calcium also will be high, and that will cause increase in contractility. Very simple and straightforward. How can I also make intracellular sodium to increase? Let me block sodium-potassium pump. Sodium-potassium pump is supposed to be like, sodium, where are you supposed to be? Sodium says that I'm supposed to be outside. Potassium, where are you supposed to be? I'm supposed to be inside the cell. Okay, sodium, go to the extracellular space where you belong. Potassium, come into the cell where you belong. So sodium-potassium pump should remove sodium from the cell. You now bring a drug that is blocking this sodium-potassium pump. If it's blocking this sodium-potassium pump, the ripple effect of it is that the net result of that is that this intracellular sodium that should have been removed will not be removed. It will now accumulate. So come back to this statement. There will now be increased intracellular sodium, and that one will eventually lead to increased intracellular calcium. And there will be increase in contractility. Very easy and straightforward. So which protein is linking increased intracellular sodium to increased intracellular calcium? And that is what we call sodium-calcium exchanger. We'll be looking at it later, and you are going to get the effect of that. All right, so just don't forget digoxin. What does it do? It blocks sodium-potassium pump. SACA, here, don't forget the calcium channel phosphorylation that helps with calcium-induced calcium release. Shikina. All right. What about any other thing here with respect to anything that can reduce contractility? And that is beta blocker. Beta blocker. They will just say this patient has arrhythmia. and the patient is given a beta blocker that helps with the arrhythmia that beta blocker can help with, by which mechanism do you think the beta blocker is actually working? Blah, blah, blah. I will show you later when we get to pharmacology, but just don't forget that it's going to reduce cramp. Just like note it, so that anytime you read the question about beta blocker, how it's going to exert its effect, is going to reduce the cyclic AMP. All right, I'm going to show you how it's doing that later. Just note it. Just like keep that one by the left hand, in your left hand. All right, contraction. Don't forget, influx of calcium into the cardiac myocyte will cause a lot of calcium to be released from calcium-induced calcium release, and that will cause contraction. I'll show you that more later too. What about relaxation? Then I need to remove calcium from the cytosol by storing it inside the what? Sarcoplasmic reticulum, so that when I need contraction, a lot of it can be released. So I will need SACA. Do you get it? You can also link it to sodium calcium exchanger. Just don't forget SACA. That's about the contracting. Let me show you one or two questions. All right. So this question number 1 here, I'll be showing you later, but just for you to note it, you need more exposure to actually keep it. But just for you to note it now, a 40-year-old female with a history of depression and hypertension is brought to the emergency room after being found obtunded in her apartment. She's hypotensive and bradycardic. On physical examination, intravenous glucagon is administered, and her condition now improved. So which of the following intracellular changes is most likely responsible for the improvement in her condition? So they've already told us here that this patient has a history of depression and this patient has a history of hypertension. So probably maybe this patient is actually on beta blocker, because with beta blocker now, the patient is bradycardic. One of the drugs you use to treat overdose of beta blocker is glucagon. Apart from that, atropine. Apart from that, normal saline. So if they could give this, I used to say gas them. You see a patient that is having overdose of beta blocker, I just shall gas the patient. Gas the patient. Give the patient glucagon. You can also check the options and pick atropine. You can also check the patient and pick something like normal saline. All right, gas them. So how will the beta blocker, how will the glucagon now help? If the beta blocker is reducing cyclic AMP, that is how the beta blocker is working. I just want you to note it. I will show you later. You will understand it. Beta blocker will reduce cyclic AMP. So if that is the case, it means this glucagon must come to increase the cyclic AMP. That is how the effect of beta blocker can be nullified. All right, so just come to the answer and just pick something like increase cyclic AMP in the cardiac myocyte. All right, so this is about this exchanger. We are going to look at it later again. Okay, so let's look at the preload.
Sorry, please, can you come again with the explanation of glucagon and cyclic AMP?
Is someone asking a question?
Yes, I am. I said, can you repeat what you said about glucagon and cyclic AMP?
All right. So basically, what is happening there is this. So that's why we say that we'll do it later. One minute, please. So basically, this is actually what we were trying to run away from, because it's still long. It's under the pharmacology. Do you get me? So beta blocker, normally they act through what we call the GS protein. So GS means stimulatory. So G protein, that's stimulatory. This GI is inhibitory in nature. So if it's stimulatory, so what happens is that adenylate cyclase is going to be activated, and if it's activated, cyclic AMP is going to be formed. It's going to be produced. So that is beta receptor. So beta receptor, they act through this GS and some other receptor that I'm not going to be talking about now. So you now imagine you give a patient beta blocker. So a patient that is taking beta blocker is more or less like you are blocking this GS. So if you are blocking this GS, what do you think will happen? It will now, the cyclic AMP level is going to drop. So the manifestation you saw in that question is more from beta blocker. So if the beta blocker is dropping the level of cyclic AMP, so if at all I'm going to give any drug, then that drug must raise the level of cyclic AMP up. Whether it's glucagon or atropine or normal saline, all of them will raise the level of cyclic AMP. So that's just how you picture it. Do you get the point?
Yes.
Lovely. So
Thank you.
that's just the summary of it. Okay. This is the heart. All right. If you load more blood into it, it's going to pump, more blood is expected to be pumped out. Do you get me? So at which phase of the heart do you actually load blood into the heart? When the heart is relaxing. So you call that diastole. The relaxation phase of the heart is diastole. So when the heart is relaxing, I load blood into it. At the end of that diastole, what have I loaded? And that will become end diastolic volume. What is the total volume I've loaded into it? Now, what USMLE wants you to bring into the exam is the relationship between preload and end diastolic volume. So if I load more blood into the heart, it shows that when I look at the end of the diastole, a lot of blood will be there, will have been loaded there. Preload is high, end diastolic volume will be high. What about end systolic volume? What does it mean? The heart has contracted, blood has been pushed out, and after that systole, I now look at the volume that is left. I will now say this one should be called end systolic volume. All right, so that's just between the end diastolic and end systolic. What can make me to load more blood into the heart? What can make the preload to increase? Probably you are giving the patient blood, or you are giving the patient fluid and the likes. So when you are giving the patient fluid, more blood volume is going to rise. Preload, you say preload is increasing. If I'm giving the patient blood, the same thing. If I'm squeezing the veins, preload is also going to rise. And that's that. So which drug do you think can reduce preload? Just to note it as you are passing doesn't mean you should sit on this. And that is nitrate, nitroglycerin. When you give it, those veins, they dilate. When they dilate, the blood will now accumulate in them. They won't go to the heart. So you say preload will reduce. So that's just about the preload. Just a simple concept. We just want you to note briefly. It doesn't mean that you should sit down on this. Look at the afterload. In question, when you read afterload, you see afterload in question. Just approximate it to mean arterial pressure. MAP, mean arterial pressure. Just approximate it to it. How do we calculate our mean arterial pressure? Our mean arterial pressure is actually equal to diastolic blood pressure plus 1/3 of pulse pressure. So if they give you in the exam blood pressure of 180 over 120, so my diastolic blood pressure is 120 plus 1/3. Pulse pressure is just the difference between the two. So 180 minus 120 will give me 60. So this one will now be 120 plus 20. Therefore, my mean arterial blood pressure is 140. So that's how you get your mean arterial pressure. So if your mean arterial pressure is very high, you say afterload is high. Look at it like that. Simply don't give yourself a headache. If it's low, afterload is low. It's just as easy as that. Just keep that one. So what can make my afterload to also rise? Sorry. So if I thought there are arterial vasoconstriction, afterload will rise and relax. So if I can dilate the arterioles, the the afterload is also going to drop. So which drug can I use to dilate the arterial? ACEI. Why, Festus, why are you shouting ACEI? Where is ACEI coming from? This is angiotensin converting enzyme inhibitor. There is a particular molecule that helps in vasoconstriction that you all know, angiotensin 2. You all know about it. If we can reduce the production of angiotensin 2, then all those arterial, they will dilate. And that is where this ACEI is also going to play. That's why they can use it in reducing blood pressure. So we'll get into all those ones. So just don't forget ACEI. It doesn't mean you should cram it, just for you to note it and how you can relate it to afterload. There is nothing to cram here at all. You don't need to cram anything here. You will see how the whole cardiology will unravel itself to you. So that's for the afterload. Just relate it to blood pressure. So when I bring down the blood pressure, I will say I'm bringing down the afterload. So most of your anti-hypertensive drug, in a way, they may, depending on what is causing the high blood pressure anyways, they can actually bring down the afterload. So, you now enter into the exam, you forget cardiac oxygen demand. I don't know what you will have said, you've eaten, you now forget this guy. No one will forgive you. Cardiac oxygen demand. You don't want to forget it. I put CAD here, and I'll show you how this can be tested. This C here is contractility. If you are walking and you don't rest, won't you be tired? Number one. Won't you be gasping for air? Number two. You are running. You are running or you are walking on the road. And you walk first kilometer, second kilometer, and you ask, do I rest small? They are saying that continue. If you eventually stop, won't you be gasping for air? So that's where this contractility, if the heart continues to contract and is now contracting rapidly, the oxygen demand by that heart is going to increase, number one. If afterload is high, afterload, the heart is pumping against high resistance. Blood pressure is high. This one high. Heart is doing a lot of work. You remember, work is equal to pressure times volume. What do you think is going to happen? The heart will be doing more work. Then oxygen demand by the heart is also going to rise. CAD, CA. What of heart? Heart rate. You check the patient and the heart rate. They will give you a question where the heart rate, first heart rate is 100. Second heart rate is 140. They will now say, which of the following will have increased in this patient? The answer is cardiac oxygen demand. Because the rate has increased, the oxygen demand by the heart is also going to rise. The last one is diameter of ventricle. You load a lot of blood into the heart. What do you think will happen to the diameter of the ventricles? It will increase. Like you put a lot of water inside the nylon. That nylon will spread out, will dilate. You can look at it like that. That's the same thing that happens when you load a lot of blood into the heart. So the ventricles will dilate. So you say the diameter of ventricles has increased. If that has increased, what do you think will happen to the load? To the work done by the heart? W, you remember the formula? W is equal to pressure times volume. If I've loaded a lot of volume into the heart, it shows that work done by the heart will also rise. Then the cardiac oxygen demand will rise. So now let me give you a scenario how this can be tested before I mention the last point here. And that is, they will just give you they can give you a question where contractility increase. Now say which of the following will increase in this patient. The answer will be, if you check it very well, likely the question is related to cardiac oxygen demand. If you check the question and they say that maybe the BP has changed and the cardiac oxygen demand will also increase, it may be heart rate. They will give you, first heart rate was maybe 80. Then the second heart rate they are giving is 120. And that's which of the following will have increased cardiac oxygen demand. The next one is the patient that is in heart failure. With heart failure, which is actually more of systolic heart failure. The heart is not contracting, systolic dysfunction. So the heart has dilated out. So it shows that the diameter has increased. So a lot of blood has accumulated in the heart. The diameter is increased. They now say that what do you think is going to be increased in this patient? So the answer will be cardiac oxygen demand. So you can go into the exam and say that you've chopped apple and you now forget how you will be thinking through the cardiac oxygen demand. No one will forget.
Boss, we cannot hear you.
The last but not the least that they've been. I hope you are hearing me.
Yes.
Oh, just to be sure. Testing for some time now is this coronary sinus.
I can't hear. Can anybody else hear?
You can be joking around.
No, I can't hear either. I think he just got
part of the body do you see
his volume. Please stop talking.
Deoxygenated blood?
You guys,
I think this is more
something
one
is
of
coming.
these quiz question. Those people that used to go for
Okay.
quiz that they have.
I think he jumped out.
Which part of
That's
the body
why.
do you see the most deoxygenated blood? The answer is coronary sinus. So it's
No,
a
he has
point
not jumped
you
out.
must
His
know.
mouse is still
So there
moving.
is really nothing much about it.
Dr. Festus, you're muted.
Can someone call him?
This is
Well,
Bola.
he's
Dr.
muted.
Festus, we can't hear you.
So sorry.
Yes, he's audible. I can hear him. I don't know how anyone
I
is
can
not
hear you
hearing.
as well.
Sorry, it's not from here. I think it's actually from when we recorded it. So I think someone amidst the crowd, just like here, muted me. That's just a joke. So I was muted, but they could not hear me. So, but it will we normalize everything back very soon. Just tag along.
We lost you like 2 minutes ago.
Volume.
Nobody was hearing you like 2 minutes ago.
The heart is pushing out anytime it contracts.
Minutes or thereabouts.
That is how much blood did we load into it? This is the heart.
So Festus, you need to go back.
Load
Nobody's hearing you. I don't know.
Well, and it's still talking, actually.
Can someone
try
call
again.
him?
Festus, we can't hear you. Oh, he's
Dr.
actually
When the heart
muted.
pumps,
It's muted.
the blood that is left
Yeah, he's
is
muted.
30 mils.
Somebody
And
should
now,
call
Not contract.
him.
Definitely
Let's see
ends
what you can call Dr.
So
see,
heart failure
The-
is heart.
We can't see the screen anymore.
but he's trying to.
I've been able to reach out to Dr. Olushola. He said it's going to reach out to the
Bulu.
Dr.
Where did you stop
Okay.
hearing me? Sorry.
Wow, Dr. Festus. Before
Where did you stop hearing me?
The page before your current page.
Cardiac oxygen demand.
oxygen demand.
Where did you stop
Yeah,
hearing me? Can someone tell
Cardiac
me?
oxygen demand.
Cardiac oxygen
Cardiac
demand.
oxygen demand. I think we can bring them our hands now. Thank you. Maybe we can bring them our hands so that our hands wouldn't hurt. Thank you.
All right. So this is the cardiac oxygen demand, the most tested concept so far, apart from those ones I've mentioned, is actually this coronary sinus being the one that contains the most deoxygenated blood in the body. Like, you don't want, it's more or less like a simple question. They will just ask is, where are you going to see which of the following contain the most deoxygenated blood in the body? So your answer is going to be coronary sinus. Very easy and straightforward. Don't forget this. So the remaining, this thing, don't give yourself too much headache. All right. Okay. So if at all you can't hear me, just call my number so that we'll know that you are not hearing me, please. Or something has happened to my presenting page, you are not seeing the slide, just call my number, because if you talk there, I won't hear you. All right. So this is stroke volume. With respect to the stroke volume, this is the volume of the blood that is pumped out per time. So it's very simple logic. Let's look at it. This is the heart. You load blood into the heart. This is the total volume of blood you load into the heart. Let us call it end diastolic volume. So when the heart pumps, this is the volume that is left. We call that end systolic volume. After systole, after contraction, this is what I have left you. So what is the volume that is pushed out? So the answer will be, which of them is more? End diastolic minus end systolic. The difference between them is going to be the stroke volume. Shikena, that's all. So now I want you to think, because most of this thinking that I talked about, I can't do them all for you. But let me give you an idea of how you can start thinking out loud that, what if they give me a question where the contraction is affected? Maybe myocardial infarction patients, where the heart is not contracting very well. They now say, which of the following entity is going to increase in this patient? The question is most likely going to be related to end systolic volume. Because the heart is not pushing out most of the blood, so the majority of them will remain after contraction. So end systolic volume will rise. So if I thought you get that, I just want you to do a thumb up so I will know you are hearing me, because if you talk, I can't hear you. So you get that. All right. So don't forget that. So that's how this, you can also think about the other ways by which the question can come here. Though the question they will give will define what they are looking for, because they can put the question anyhow. Right? They might even say that the patient had a road traffic accident, lost a lot of blood. Which of the following is going to reduce in the patient? The answer is going to be end diastolic volume. Why? A lot of blood has been lost. Enough blood will not go to the heart. So the volume that will be loaded to the heart will now reduce. So end diastolic volume will reduce. They may say that the patient is giving a normal saline. They are giving the patient fluid. That which of the following will increase in this patient? The answer is going to be end diastolic volume. Very easy. So you can think it anyhow you like. So keep it simple. Now, what of ejection fraction? It's a fraction. I give you an apple. I say you should take a bite. You take a bite. How will I know the fraction that you've taken the bite of? That is the bite you took divided by the total apple I gave you. What did we give to the heart? End diastolic volume. What did the heart remove? Stroke volume. So what is the fraction? Ejection fraction. Stroke volume divided by what we gave the heart. End diastolic volume. Very easy and straightforward. So now they are now going to relate this ejection fraction to heart failure. You all know it. It's not that maybe we are teaching. We are not teaching. We are just reminding you what you know and how the questions can come. Heart failure. This is heart failure for you. That you know, it can be heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. You can go into step 2 exam and forget this. No one will forgive. In fact, they will crucify that candidate head down. You forget heart failure with these two, they won't forgive you. So if a patient, you look at the patient has symptoms and signs of heart failure. You now check the ejection fraction. Let me assume that the ejection fraction should be, the normal one should be 50. And you now check the ejection fraction is now like 20%. So you will call that heart failure with reduced ejection fraction. You check the question, you are seeing symptoms and signs of heart failure. You now check the ejection fraction that is given is still like 50%. You call this heart failure with preserved ejection fraction, which means in the exam, you just look at, can I see symptoms and signs of heart failure? Let me look at the ejection fraction. Shikena. All right, so that's about the ejection fraction and how that can be tested. What about the cardiac output? This is the cardiac output. This is a formula. Cardiac output is equal to stroke volume multiplied by the heart rate. So if I want to increase the cardiac output, I can increase the stroke volume. I can also increase the heart rate. Any of them that I increase, the cardiac output will increase. Shikina. Let me give you a question. This is a patient that the heart rate has increased from 80 to 120. Which of the following is also likely to increase in this patient? Cardiac output. Very easy. Cardiac output will also increase. After a while, it can drop again. I will show you why it's going to drop. All right. So that's with respect to heart rate. Just think simply. Don't go and be doing that. Maybe there is one trap they've laid there. There's no trap anyway. Just look at it simply. Like, think simply and be like, the answer should be A, the answer should be B, and like, make it quite easy. They give you a question where they give the patient digoxin, where there is increase in contractility. So with that, stroke volume is going to rise. Definitely cardiac output is also going to rise. So very easy and straightforward. Festus, why did you put arrow on exercise, early stage of exercise, and this other one? You go into an exam, you now forget exercise. I don't know what you say you are thinking, that I go into the exam, I forget exercise. It's not allowed. In fact, it's not allowed. It's not allowed. When you become cardiologist, you won't even tolerate a candidate that doesn't know the significance of exercise. Exercise? You don't know it? Something is wrong. All right, let's look at it. What do we want to take into the exam here? All right. So when a patient is exercising, what do you think the body of that patient is thinking? This muscle, this skeletal muscle, they are working. The body will want to increase the blood flow to those muscles that are working. Those muscles that are not working, that are not part of the exercise, and the organs that are not part of the exercise, the body will reduce the blood flow to them. Is that not what you would have done if you were to be God? The skeletal muscles that are contracting, relaxing. You want to increase blood supply to them so that at least they will eat more food. Right? So if you now have some muscle that are not actively in the exercise, you will reduce blood flow to them. What are they eating for? So that is the thinking of the body. All right. So how do you think the body achieved? That's question number 1 in the exam. How do you think the body achieved increasing blood flow to those skeletal muscles that are actively contracting? The way the body achieved that is through local metabolite. What do we mean by local metabolite? When the skeletal muscle is contracting, relaxing, some local metabolites are released like CO2, hydrogen ion, adenosine, lactic acid, and potassium. We call them chalk, C-H-A-L-K. They will ask you in the exam. In this actively exercising muscle, which of the following is likely to increase locally? Just check. It might be potassium they will put there. It might be adenosine. It might be lactic acid. That lactic acid you think they will put there, they won't put that one. It will not be all this adenosine, CO2, hydrogen ion, and the like they will go and put there. So that you just note that we'll get there. I'll show you again. So all these local metabolites, they will cause vasodilation. So when they dilate, when the blood gets to that region, there will be increase in blood flow. And that is how body increases blood flow to the active muscle. All right. So what about those organs that are not part of it? How can we reduce blood flow to them? Through catecholamine. Catecholamines will be released. So those catecholamines, like all these, your norepinephrine and the likes, they are going to go there and cause vasoconstriction. So when they cause the vasoconstriction, there will be reduced blood flow to those inactive muscle and organ. That is the thinking of the body. All right. So, Festus, you just mentioned that catecholamines will be released. These catecholamines, they also have some other additional effects. You say, hey, what are those effects? One, they will go to the heart and increase heart rate. They will increase contractility of the heart. There will be increased heart rate, increased contractility. What do you think they will do again? They are going to cause phacoconstriction. Phacoconstriction. When you are constricting the veins, more blood will leave the vein and go to the heart. So you say there is increase in venous return with exercise. All these things, they are looking normal to us now. Festus, why is USMLE this particular about exercise? All right, I will show you. But before that, let us look at the results of all this exercise. So definitely a patient that is exercising, the heart rate of that patient will increase. You already know, you can pick the correct answer for that in the exam. The contractility will increase. You can pick correct answer for that in the exam. Stroke volume will increase. You can pick correct answer for that in the exam. Cardiac output will increase. You can easily pick that. USMLE will not focus on all these ones. There is one that USMLE will focus on, and that is systemic vascular resistance will reduce. If you are not very careful, they will give it and you will miss that question. Let me show you why systemic vascular... In fact, this is the most important statement in exercise. Systemic vascular resistance will reduce. So don't forget that we have some vessels that vasoconstrict. We also have some vessels that dilate. The vessels that you see in those actively exercising muscle, they dilate from the effect of those local metabolites. So you have more vasodilation than vasoconstriction. So when you look at the net effect, the systemic vascular resistance will drop. This is interesting. What does that one mean? A patient that has hypertension. Exercise has effects. In exercising, it has effect in bringing down the BP. A patient that is not exercising, most of this systemic vascular resistance that is dropping will not really occur there. And the net result of that is that the BP in a patient with sedentary lifestyle may start rising. So all of them are linked together. You can deal with a paper with that. So never forget this statement. They will ask it in the exam. This is the most tested concept about exercise. Forget that at your own, because the others you can easily reason them out. This systemic vascular resistance reducing, that's the most tested one. When you are reading question on exercise, just be very sure that this is not what they are testing. This statement here, reduce systemic vascular resistance. All right, so that's that about this. Never forget they will ask that. All right. Okay, I think that's the most important statement I need to make there. The others, you can easily deal with them. What about the heart rate? They will give you a question where heart rate is just increasing. If heart rate is increasing, think about it. I'm going to demonstrate it here. In between every poo that I say, the heart has relaxed. Do you get me? When the heart relaxes, blood will be loaded into the heart, number one. Point number two, it is during that relaxation that heart is eating. It is during relaxation that heart eats. What do I mean? It is during diastole that you feed the heart. Heart that is working, that is contracting, you feed it during diastole. What this statement means is that they give you two heart rates. One is 100, the other one is 120, 150. It's still relaxing. Compared to it shows that the heart is not actually relaxing to it. So that kind of patient can easily go to heart failure just from tachycardia. Because after a while, if the heart is not relaxing, it's going to fail. No wonder you need to address that patient with arrhythmia. You need to tackle it. Because if the heart is not really hitting, after a while, those heart muscles, they may start dying. So please never forget this. So diastole, relaxation is shortened when heart rate is very high. So, and there will now be another point again is diastolic filling time. So you don't also have enough time for the heart to relax for blood to come into the heart. After a while, if enough blood is not coming into the heart because I'm not relaxing enough for blood to accumulate to come into me, after a while, I won't have enough to push out. So stroke volume will reduce, cardiac output will reduce. I made some points here about this increase in heart rate, how questions will come. One, it is during diastole that the heart actually fade. Number one. Number two, when the heart rate is very high and you don't quickly tackle it, after a while, the patient will go into shock. Cardiac output is going to fall. The patient can go into heart failure. Do you get me? Because heart is not relaxing enough for blood to also come into it. Just look at it like that if you wish. What of pulse pressure question? This is BP. So this is BP. You have 180 divided by 120. This is systolic BP. This is diastolic BP. Pulse pressure is just the difference between them. That's all. That's pulse pressure. So the question they give in the exam is, they will give you a patient with very wide pulse pressure. You don't even need to calculate before you know that this is very wide now. They give you something like 180 divided by 60. The pulse pressure you will be getting here is going to be very, very wide. Like the diastolic is so small compared to the systolic. So you say pulse pressure is increased. Now, under which condition will pulse pressure increase? Don't give yourself any headache here. Don't cram anything here at all. Because they are not actually going to list them out for you to just, they won't give you this kind of question for you to be thinking in the dark. You will see that you've calculated, the only assignment you have here is to calculate the pulse pressure and be like, the pulse pressure here is high. They will now ask you that, what do you think is responsible for that wide pulse pressure or something like that? Just check through the question. The answer is there. It can be something related to obstructive sleep apnea. They will just tell you that this patient, when the patient sleeps, you are seeing this patient snores a lot. When the patient wakes up, the patient does not have a refreshing night. The patient is actually the child start portraying the obstructive sleep apnea for you. Then definitely that's the cause of the wide pulse pressure. Very easy. So in the exam again, if they like, they can portray this anemia. You just check through. You check through the option. Question. You can't see anything. You now see part of the question. You now see the PCV is low. Or hematocrit value is very low. Just say that anemia is what is causing it. Another thing is hyperthyroidism. You don't need to cram it. Just check through that question. You will see it there. Just pick it and go. You are not going to synthesize any answer from the moon. Everything is within the question. Just look at it and bring it out. And that is why when they give out their clinical scenario, it's very rare for you to answer that question without a clincher in the question. So all those stuffs they are there. It's not that maybe you need to have linked something to something before you now say that this is no. The answer will be there. What of reduced pulse pressure? You see something like 140 over 110. And let me just give something like this. Yeah, like how come the diastolic blood pressure is this high? So reduce, reduce pulse pressure. So when you also see a clincher in it that, okay, this is actually what is causing the reduced pulse pressure. All right. So the last point I'm going to make, I have two more last points to make under this pulse pressure. What is the factor that can make systolic blood pressure to rise? So they give you a question like this where the blood pressure they give you is 180 divided by 80. You just look through the BP and you're like, systolic is very high now. What is causing this thing? Quickly check through the question. How old is this patient? Do you get me? How old is this patient? If the patient is quite old, you'll be thinking towards aortic stiffening. Just pick it like that. He's quite old. Just say aortic stiffening. Isolated systolic hypertension. All right. If you check through that, you don't see most of the time what makes the systolic blood pressure to go up, or that the factor that can make systolic blood pressure to increase is stroke volume or cardiac output. So if the stroke volume increases, systolic blood pressure will rise. If the cardiac output increases, systolic blood pressure will rise. Which factor determines the change you see in diastolic blood pressure most of the time is total peripheral resistance. So if the total peripheral resistance is actually reduced, the diastolic blood pressure will reduce. If the total peripheral resistance is increased, diastolic blood pressure will increase. Very easy and straightforward. Mean arterial pressure, I've told you, I think I wrote this formula out. Though I've never seen a place where they say calculate the mean arterial pressure. Maybe on you, they may just give you a BP, give you a clinical scenario and just say, what do you think is the mean arterial pressure in this patient? So just for you to apply the formula, diastolic blood pressure plus 1/3 of pulse pressure. So diastolic plus 1/3 of the difference between systolic and diastolic. Then you come down to the Starling curves. It's just a curve. There is nothing about it. It's a qualitative reasoning. Let me show you. In the exam, they will draw the curve for you. The curve will be given like this, and they will label this one as normal or at rest. They will now give you the curve of the patient. So what is the y-axis here? Stroke volume. What is the x-axis? End diastolic volume. The volume you load into the heart. So this is the normal. Let me assume the first one they are giving us is below the normal. Let me just call this one X. They give us two curves below the normal. The second one here is Y. All right. So the point I want you to get here is that any curve that is below normal, the heart has failed. It's just as easy as, because this is stroke volume, it shows that the heart is not pumping enough out. Heart failure. So let me assume that this X, this lowermost curve, is the one they give for the patient. They now tell you that the patient is treated. Where do you think the curve is going to be? Have you ever seen a patient that is treated for heart failure and that patient can run like a normal patient? No matter how you treat it, the patient, it cannot be normal again. It's not possible. The heart has failed before. You can't be pushed because it can fail again. It can fail again. You need to be very careful. In fact, most of the time, when you treat a patient for heart failure or acute heart failure, you are indirectly just converting the patient from acute heart failure to chronic heart failure. The patient has heart failure, is heart failure patient, until proven otherwise. So it can be normal. So no matter how you treat it, you help the patient. The patient cannot be behaving like a normal patient. So it can get up to the normal. Very simple concept. So the patient has heart failure. Now see the patient is given a drug. How do you think the curve will be? They will now start drawing a curve above normal, below the heart failure, this one, that one. You just know it's definitely going to be. The drug you are giving the patient will only improve the condition a bit, but it can get up to normal. So it will be between normal and heart failure. Very easy and straightforward. They tell you that this is a normal thing. All right, yeah, thank God. All right, so they give you a question here that this is a normal curve. They now tell you that the patient, what do you think the curve will look like for a patient that is exercising? All right, yeah. They give you this question. This is for normal. They now say that they draw another one for you and be like, this is the one for the patient that is exercising. Like two curves or two curves in the diagram. The question is, what do you think is responsible for the nature of the curve for this patient that is exercising? You have numerous answers to pick. Number one, release of catecholamine. The heart is contracting more. Increase in preload. More blood is going to the heart from vasoconstriction. Reduction in systemic vascular resistance from vasodilation. So more blood can flow out like you are reducing afterload. Shikena for the exercise. All those things we mentioned about exercise. The one I say you must never forget. If that is what they are testing, you know what? You just pick the answer. Systemic vascular resistance is actually reduced in a patient that is exercising. All right, that is for this curve. So if you are told they ask anything on it, just pick the answer. That's why it's going to be more than normal, like above normal. More blood is flowing out of the heart from constriction, from increase in contractility. More blood is going to be loaded into the heart from increase in venous constriction. More blood is also going to flow out of the heart from increase in preload together with reduction in afterload. That reduction in afterload is coming from reduction in systemic vascular resistance. Easy and straightforward. So there is really nothing to cram here. Just look at the question and you will be fine. I wrote something here, always correlate the clinical description they will give in the exam. Correlate it to the graph they are giving you. So the graph they will give Dr. A might be for exercise. The one they will give to Dr. B might just be the one that related to heart failure. Very easy and straightforward. I didn't. All right. Oh. Wake up, wake up, wake up, stop sleeping. Someone will be like, oh, you are
We're not sleeping now.
No, you are the one that's not sleeping. Some people are sleeping.
Okay, you are sleeping.
How can I afford to sleep?
If I say people should be talking now, they will be like, leave Festus alone. I'm actually the one he was talking to. I've been sleeping for about 2 hours. It's all right. So if you look at it, nothing. You see, if you look at it, nothing much to actually deal with. All you need is you are just the one giving yourself unnecessary headache. You are not a cardiologist. USMLE does not want you to become one before you come to US. All USMLE need is just have an idea. Whatsoever you know, even if you are a consultant, they will teach you. In fact, whatsoever you might have learned in this thing, you drop them. You will drop everything as you are going to, and they will drop them. They will train you to be like them. The training is on weekly basis, not once in a while. So all you need is just to pass. And what can make you to pass, basically, is just to pick 1 or 2 points. And after the step 1, step 2, step 3, some people will not even do anything related to cardiology again in their life. So how come is now you want to hang yourself all because of cardiology? No, now you don't need that. Just pick 1 or 2 points. Pick it. Okay, with respect to exercise, what they are most likely going to test me on, systemic vascular resistance, and with exercise it drops. So if I thought they are asking me a question why exercise is important in a patient with that is having high blood pressure, I already know it's going to help in reducing the blood pressure in the way. Exercise. It just be like pick the main thing. The remaining you will be extrapolating it them from whatsoever points you might have picked. Then it's not compulsory you solve for your U word. That's another lie. The exam does not repeat those questions. It's not compulsory. They brought MBME this, MBME that. No. If you don't know, you don't know. If you don't know, you don't know. It's just as simple as that. You don't know, you don't know. Because when you get into the exam, for those that have really just realized that you don't even see most of those questions. And all the questions you will see, you actually just need to do 1 or 2 thinking on them. More or less like you are just going for a scholarship exam that you just need to think and be. And I told you, as I said earlier on, all those questions. Now, if they give you a question on cardiology, if they give you 10 questions, you are most likely still going to get 6 out of the 10, despite the fact that you are not going for the exam yet. So how come people, when they come back, they are like, it's fair. They were busy reading big things, and as a result of that, when they see simple thing, they don't even know that it's simple. Just be like it's big. Then volume of the question. In the exam, the volume of the question they will give you will be very long. When you see the question very long like that, most likely you don't need to read that question before you pick your answer. Most likely you don't need, because these guys, they have psychologists that set those questions with them. It is in Africa that you set a question and you just believe that go and answer it within 1 minute 40 seconds. I don't care whether you will get it, and they will be giving people that could read it and get it prize. No, they plot graphs for everything. So if the question is too long, When you get into the exam, you realize the question is very long. Most likely, you don't need to read that. Most likely, you don't need to read it finish. Likely, the answer is just what you will need to answer that question is at the end of the question or the beginning of the question. So you just quickly check the option, then quickly check the end part of the question. If you don't see the clincher there, go to the first part of the question. You still do not see the clincher. It is at that moment you will not be like, okay, let me read the question. It shows that you know what you are looking for. And that's that. So please take it very easy. I'm going to give us 25 minutes break. I know you've been expecting that. You say we should think simply, and we are just doing. Shall let us rest small. Okay, go for 25 minutes break. In the next 25 minutes, that's going to be next 25 minutes according to my time here. We'll be meeting again. Thank you. You should cram anything there. What about the resistance pressure flow? In the next, I think I should allow you to go for a break of 10 minutes. So after that, you come back, we continue. I think you will be happy to go for a break. Some people are already waiting for that anyways. All right. So thank you. In the next 10 minutes, we'll continue what we are doing. All right. Okay, let's continue. So now, what is going on with respect to resistance, pressure, and flow? See, please, I use God beg you. There is nothing here to cram unless you just like cramming. The only point you want to note in this area, one of the few points you want to know in this area is this formula. So, this formula is very, very important, and they will give you a question on it. So, it's just the same formula, you know, that is flow is directly proportional to the radius raised to power 4. And that's that. You want to note this formula very well. So what happens is that in the exam, they will give you a vessel. And that vessel, they will say the radius is R, or they give you the diameter of it. They will now tell you in that question that the diameter is double. The diameter is a drug is given that makes the diameter to double. What do you think will happen to the flow? Okay, let us look at it. Initially, the radius is R. That's your assumption. So the next radius after that drug is given, okay, let me change it. All right, the diameter is given, you just pick it as D. Diameter, the radius is supposed to be diameter divided by 2. So the question now says that the diameter is double. So the diameter we have in the next one is 2D. Right? So if it's double, the radius here is going to be 2D divided by 2. So that's the second scenario here. First one. All right. So my radius here is D divided by 2. My second one, when the drug is given, the diameter is double. So my radius, new radius will be 2D, which is that double diameter divided by 2. Let me assume that for simplicity's sake, that D divided by 2 is equal to R. So if the diameter is double, please, you will see where I'm going. So here now, my radius is going to be 2D divided by 2R, 2R. So what that means is that in the exam, you can equate the diameter to radius. When they give you diameter, just say diameter is equal to radius. So because this is still the same thing as the radius is given as R, when they say the diameter is doubled, it's the same thing as 2R, 2. The radius is also double. Shikena. So because I've seen a situation where when they give diameter in the exam, people will be like, they will now be saying diameter divided by 2. That will be making it complete. Just equate diameter. If the question mentioned diameter, assume that diameter is radius. So if the question says that the diameter is double, just assume that the radius is double. All right. So that is with respect to this point here. So in that scenario now, what it means is that if they give you the question, a drug is given, and that drug dilates the vessel, the diameter is double, I will just say that my first radius is R, my second one is 2R. The question they will ask is, what do you think will happen to flow? That's your question. So when we were in secondary school, they taught us about all this variation. This is a direct variation. So if you want to introduce constant here, you will say Q is equal to KR raised to power 4. You are now going to make this K the subject of your formula. So this will now turn to K is equal to Q divided by R raised to power 4. So that is how you get your K. So anytime you take Q divided by R raised to power 4, you must get a constant. So that is what we give birth to Q1 divided by R1 raised to power 4 equal to Q2 divided by R2 raised to power 4. So permit me to just clean this. At least you already know what the formula looks like. Q divided by R. So let me clean this because this area, so that when you see the question on it, you will not be saying that you are confused. So now, I will just say Q1. Let me write the formula here again. Q1 divided by R1 raised to power 4 equal to Q2 divided by R2 raised to power 4. So what is my Q1? What is my Q1? I will assume that my Q1, the question did not mention Q. I will just say my Q1 is equal to Q. The question did not give me anything about R1. I will just assume that my R1 is equal to R raised to power 4. Equal to, I don't know what my Q2 is. That's what they say I should look for. What about my R2? I've already given my R2 that R2 is double of R1. So my R2 will be 2R. Can you see? Raised to power 4. You can see I put that 2R in bracket. And then I put everything raised to power 4. So this will now be Q divided by R raised to power 4 equal to Q2 divided by 2 raised to power 4 will give me 2 times 2 times 2 times 2. That's like 16. R raised to power 4 is R raised to power 4. R4 can cancel R4, right? So therefore, if I cross multiply, my Q2 is equal to 16Q. That's the answer. So what this means is that amidst all the options, they will now say that by what factor has the flow increased? Their answer is 16. By what factor has the flow increased? The answer is 16. Festus, do I need to now be calculating all this thing in the exam? To be very sincere, if you can't just look at the question and just say this is the answer, you need to calculate it, whether you like it or not. You need to calculate it. So by this, so that you'll be able to pick correct answer. But because flow is directly proportional to R raised to power 4, if they tell me that the radius is double, I know that the flow will increase by factor of 62. That is double 2 raised to power 4. That's just your thinking. If they say the diameter, the drug dilates the vessel by factor of 3, that is initial diameter is D, the new diameter is 3D, then definitely I will be going for 3 raised to power 4, 3 times 3 times 3 times 3. So the flow will have increased by factor of, is it not 81 if I'm not mistaken? So something like that. Please never forget this concept. Q directly proportional to R raised to power 4. It's just normal variation question. They will ask you, they will mention it, you will see it in your question bank. The next one is about the resistance. Resistance is inversely proportional to the radius. So resistance is inversely. Let us bring out the formula for that one too, so that you get used to it. I just need to do it so that when you are listening to the video, you can easily do it by yourself. And we know we have a lot of people that won Olympiad, mathematics Olympiad, yeah? So R inversely proportional to R radius raised to power 4. So let me divide this. So I want to introduce my constant. This will be R resistance is equal to K multiplied by 1 over R raised to power 4. I will make my constant the subject of the formula. So R multiplied by radius raised to power 4 is equal to constant. What does this mean? My resistance 1 multiplied by radius 1 raised to power 4 is equal to resistance 2 multiplied by radius 2 raised to power 4. So if the question says that the radius increase by 2, so this one will now be, I will assume my first resistance is R multiplied by my first radius is R small r raised to power 4. My second resistance is R2. My second radius is 2R raised to power 4. So this will now be R multiplied by small r raised to power 4 is equal to R2 multiplied by 2 raised to power 4 is 16 multiplied by R raised to power 4. Can you see? So R raised to power 4 can cancel R raised to power 4 here. Therefore, my R2 is equal to first R divided by 16. So my final answer is going to be like the resistance will reduce by factor of 16. If you look at me, I say reduce by factor of 16, or you say increase by factor of 1 over 16. Increase is multiplication, reduce is division. So reduce by factor of 16 or increase by factor of 1 over 16. So in the exam, check what they wrote. If they say by what value do you think the new resistance will increase? The answer is 1 over 16. If they say by what value do you think the new resistance will reduce? The answer is 16. It's not going to be 1 over 16, so that you won't go and make that mistake. Very well. Please note it. That's how this area will be tested. Expect question on this. It's just a drug that is dilating. They might say the patient was placed on one vasodilator. It might be a nitrate. It might be a ACE high inhibitor. Any one they mention. But they will definitely tell you that the resistance or the flow is changing. The next important point you want to know in this area is about arterial. What do you think? You've heard about total peripheral resistance before. What do you think is the major contributor to the total peripheral resistance in the body? The answer is arterial. It's just a simple question. Arterial. Just pick that and move on. All right. The other aspect they wrote here, there are things you can easily think about. It's about viscosity. When the blood is very viscous, the resistance is very high. Resistance means that I can't move. I can't move easily. Look at it like that. So when the question says the blood is highly viscous, definitely the resistance is going to be high. What can make a blood to be highly viscous? Maybe you are dealing with polycythemia vera, where you have a lot of RBC, a lot of platelet, a lot of WBC. Do you get it? So all those blood cells, their numbers very high in the blood, they will make the blood to be highly viscous. Very easy and straightforward. It might even be multiple myeloma, where all those abnormal proteins, immunoglobulins, are produced. So the blood is going to be highly viscous. The resistance is also going to increase. So these are just ways by which resistance can be tested in the exam. Just these 2 points, they are very okay for you. You come down to what we call the cardiac and vascular function curve. There is nothing here. It's just a qualitative reasoning for you. In the exam, they will draw the graph for you. Your own is just to look at what they draw or what they've drawn and to extrapolate it. Someone that is in primary 5 can answer this question. If you are missing it, something is wrong. That's just for you to see how simple it is. Now look at it. This graph, we have what we call the cardiac curve. We have vascular curve. The cardiac curve, when they give you the graph, they will show you. I will show you a question. They will show you in that question that this one is actually the cardiac curve. They will label it. They will label the second one that this second one is a vascular curve. Point number 1. They will now give you the one of the patient, that the patient one is this one. They will try and put it there. The one they are giving you, just look at it. Is it cardiac curve or vascular curve? So if they give you the one that is related to the vascular curve, all your thinking should be on vessel. If they give you something related to, if they give you something related to cardiac curve, all your thinking should be on heart. If they give you something related to vascular curve, all your thinking should be on vessel. If the curve they give you, they are related to both heart and the vessel, your thinking should be on total peripheral resistance. Relax. Let me show you again. Look at this first curve, diagram here. This red one is the cardiac curve, function curve. The blue one here is the vascular function curve. I will now look at the one for the patient. It's related to the cardiac function curve. All my thinking will be on the heart. That's number 1. So when I'm looking at the option, I'm looking at any option that's related to the heart. I don't even know the question. I just see the one that is changing. I will just start looking at the option. This option is related to the heart. This one is not related. All the others are related to vessel. I will just go and pick the one that's related to the heart. Even if let me assume that time does not permit me to read that question. Merely looking at the curve, I already know what I'm dealing with. So look at this second diagram or graph. The one that is changing here is the vascular function curve. All my thinking will be on vessel. So I will just look at the option. Can I see anything related to vessel here? I will just pick that as my answer. I look at the graph. I realize that they are giving me the one for vessel and the one for the heart. Both of them are changing. Then, in this case, all my thinking will be on total peripheral resistance. From my own psychological analysis, I realized that the one you are most likely going to forget is this total peripheral resistance. And that is why I wrote this one out as TPR. I bolden it, that when you see the two of them changing, be thinking towards total peripheral resistance. Now relax. Look at these y-axis in your exam. What are they putting there? If they put, let me be sure that you are hearing me. Okay. You are with me. Can you hear me? Dr. Winifred, can you all hear me? Okay, you are hearing me.
We can hear you.
So
Yes.
if you look at this y-axis, they put venous return here or cardiac output. So if we look at this curve, this graph, it is the cardiac curve that is changing. All my thinking will be on what? Cardiac output. So what it means is that if the curve they are giving me for the question is above the normal, it shows that my cardiac output has increased. So what could they have done to the patient that will make my cardiac output to increase? I will look at the options. Oh, they gave this patient an inotropic agent like dobutamine, which is making the heart to contract more, then the cardiac output is increasing. I look at this question. The graph they are giving me is below the normal. So the cardiac output, because the curve they are giving me is related to the heart, I'll be thinking more towards cardiac output. It has reduced. Then I'll be thinking, what could have happened to this heart that will make it not to contract the way it should? Maybe I'm dealing with myocardial infarction. Look at the curve here for this graph B. The vascular one has increased for number 3. This vascular one, the y-axis is talking about venous return. What could they have done to the patient that will make the venous return to increase? Maybe they are giving the patient fluid. Maybe they are giving the patient blood. Maybe they are giving the patient a vasoconstrictor. Do you get it? So if I look at it, the curve they are giving me is below the normal. I'll just look at it. Venous return has reduced. What could have happened to this patient that will make the venous return to reduce? Maybe this patient is bleeding. Can you see all my thinking is actually channeled towards the vessel? So that is how you look at it. Then when you now look here, you are seeing they are giving you both vascular and the cardiac. Just look at it. you are dealing with total peripheral resistance. And the caveat here is that if the curve is above the original one, total peripheral resistance has reduced. Because what this one technically means is that something has happened to the total peripheral resistance that is making the cardiac output to increase. What is that thing? A reduction in total peripheral resistance. If the resistance has dropped, more blood will leave the heart. That's why this one will be the heart. So if the curve is below, so it shows that something has happened to the total peripheral resistance that is making the cardiac output to be lower. Maybe total peripheral resistance has risen. And that's all. So let me give you a question for you to look at and just assume, imagine how it's going to be. I just want you to look at the curve and no, not this one. So let's look at the this is more of the answer to that one. So look at this graph now. I just want you to look at it. This is the question they gave in that question. We've not even read the question. Just look at it. What is changing here is the cardiac output, cardiac curve, and this one is lower. The curve they are giving you itself is lower than the one for the original cardiac they are giving you. What do you think will have happened to this patient? Can anyone make a guess? You've not even read the question, but can you make a guess?
MI, heart failure.
Heart failure.
The heart rate has
All
dropped.
right, sorry. Can you make a guess?
Cardiac infarction.
Anyone?
MI, heart failure.
Contractility.
Exactly. That makes sense. So that's how you will be looking at it in the exam. You just look at it. It's only the cardiac that is changing here. All right. So you just look at it that it's only the cardiac that is changing here. So you'll be thinking more towards MI. Very easy and straightforward. So nothing to worry about. So if you look at this one, the one that is changing here is the vascular one. Even if they do not label it very well, I can see that this is venous return. And it is this blue one that is changing. All my thinking will be around first. So what do you think could have happened to this one that is making it to be like this? Anyone?
Blood loss. Increased blood loss.
That's all. So that's
Blood loss, bleeding.
Okay, very easy and straightforward. So we are done with that. So you can go through the others. So there is nothing. Now, what are the causes of so far from what we've done? I just want you to write it in the message box. So far from what we've done, what do you think can cause reduction in total peripheral resistance in your question, cardiology question? Just write it. Let me see. Exercise. Someone gave up. Oh, sorry. All right. Further mathematics. When did we do further math? We didn't do further math at all. God have mercy on the person that say we did further. Vasodilator and the like. All right. So far, I only asked question about the one we've done so far. So the answer is actually the exercise. You got it. So now, never forget exercise. That's how exercise will be tested again in the exam. Can you see that USMLE is actually quite conceptual? You just need to note those things and move on. All the other unnecessary details, just ignore them. So the next point I'm going to leave with you is arteriovenous shunting. So arteriovenous shunting. Let me illustrate how arteriovenous shunting is. We mentioned that arterioles, they are the one that cause the total peripheral resistance. Like they are the one at the toll gate in Lagos, for those that are from Nigeria. So permit me to just say this is the vein. Permit me to say these are the arteries, or this is the artery. So in arteriovenous shunting, so normally when the blood gets to these arterioles, they will regulate it. The flow will not be, they will be checking, doing all that. So they are the one that will that are responsible for the resistance. Resistance is like we don't want it to flow easily so that you don't just be causing all manner. So they reduce the flow. So that if they don't reduce the flow, the blood with the force that the blood is coming with in the artery, they will go to the capillary and start bursting them. God is so wonderful. God put arterioles there to reduce the flow. So that when they get to the capillary, the flow is not that much. Then they can regulate it. Then a lot of oxygen extraction can occur. So in arteriovenous shunting, you just take the blood directly from the artery and you connect it with the vein. So you bypass this. So if you bypass it, the way the blood is rushing, is coming from the artery, is going to enter into the vein like that and it's going to push it. Do you get it? So all this resistance, you say, is lost. So therefore, when you see a question with reduced total peripheral resistance, another point you don't want to forget in the exam is arteriovenous shunting. Now, that is the point. Which condition are they going to put in exam where this arteriovenous shunting will be portrayed? And that condition is actually hemodialysis. They will just give a condition, just give a scenario and just say that maybe arteriovenous shunt is produced. Which of the following are you likely going to see in this patient? The answer is reduction in total peripheral resistance. That's why it's the only one I put my arrow on. The other stuffs you can easily extrapolate them. Spinal anesthesia. The patient that is actually placed on spinal anesthesia, what you are going to see is that one of the manifestations you can see from spinal anesthesia is more or less like those vessels, they can dilate. So when they dilate, even the veins and the likes, when they dilate, blood will not be able to, venous return is going to be affected. That's basic point. I just need to leave with you. All right. Then we come down to this area in the cardiac physiology. You don't need to cram anything here too. Nothing to cram. Just take it simply like that. Don't cram anything. So I will show you how you'll be looking at it. All right. They will give this curve in the exam. So the way they will give it is something like this. The way they will give it is something like this. Can you see? Just something like this. That's how they will give it. So let us look at the way the question will come. So they give the curve like this in the exam. They'll just put it there. Anyhow they put it. Then they will put the normal one and put the one for the patient. So anytime you see this, don't even try to be like you've crammed something or anything. Don't bother. Just do what we want to ask you to do here. You don't need to be launching any explanation in the exam. The explanation does not come because you won't have the time to be launching unnecessary explanation. So you are going to be using this mnemonic, MAM, Coco. MAM, Coco. So when they give you the curve, you just quickly pick your pen. You start from the, I think this is regarded as the left, Abby. Okay, I call it right. This is like right. You just label it like this in this direction. MAM, M-A-M. You look at the angle, edges rather. M-A-M. That is MAM. Then you put the Coco there. C-O-C-O. Now, the advantage of this MAM Coco is that it first of all tells you, if they ask you, where is the aortic valve closing? Where is the aortic valve opening? Where is the mitral valve closing? Where is the mitral valve opening? You already know. That's all. You just put MAM Coco. I already know my mitral valve closure is here. My aortic valve opening is here. My aortic valve closure is here, this angle. My mitral valve opening is here. That is that. The next one is, where will you hear the first out sound? Where will you hear the second out sound? What is responsible for the first out sound is mitral valve closure. So I will just check, where is my mitral valve closing? It is this angle. My answer is here. They will label it ABC. If you look at it, it's just qualitative reasoning. You don't need to be doing too much reading and be explaining when the mitral valve close, They will eat themselves. Now give rise to this sound. No one cares about all those stuff. You just want to pass because you may not even do cardiology again after step 1 and step 2, step 3. So you just want to pass, get the question right and move on. So this is my S1, my first R sound. The question has that, where do you think the second R sound is going to be heard? I will just quickly check, where is the aortic valve closing? My answer will be here, S2. Just check it and just quickly put that, and that's all. All right, so that's that. The next important point you want to get here is just for you to for your information. You see, look at the way they put the arrow. The arrow is also going in this direction, like anti-clockwise direction. Can you see the way you put the arrow? Anti-clockwise direction. If you look at the arrow here, number 1, the arrow is going up. Look at it, arrow is going up. So which means that your y-axis is actually the left ventricular pressure. Your x-axis is left ventricular volume. So if I look at this arrow is going up, it shows that my y-axis is changing. However, my x-axis remains the same. You call this isovolumetric contraction. With that contraction, the pressure is increasing. Do you get me? Then when it gets to this level, aortic valve will open. When the aortic valve opens, what do you think is going to happen to the volume? Because blood is going to be leaving the left ventricle into the aorta. So what do you think will happen to the left ventricular volume? It will start reducing. That is why you see the arrow going backward, because it's reducing. Because blood is leaving the left ventricle. Then after a while, when it gets to a level, the aortic valve will close again. Then I will hear my S2. Can you see the S2? As it closes, what do you think is going to happen again? The heart will be doing, it will be relaxing. As it's relaxing, I will have isovolumetric relaxation. The pressure is dropping. Very easy and straightforward. So if I'm loading blood into the heart, preload, can you see left ventricular volume is increasing for the preload? Then contraction, then opening of the aortic valve, blood is lost into the aorta, then heart relaxation. It's just something you can reason out. You don't need one special teacher to show you this. Simple and straightforward. So the next important question that they can also give you here, apart from where is the mitral valve closing, aortic valve closing, where do you hear your S1, where do you hear your S2, is about the other heart sound. Where do you think you are likely to hear your S3? Where do you think you are likely to hear your S4? All right, so let's look at the S3. So this is how you'll be looking at those as sound. God is good. So this is S1, S2, S3, S4, S1, S2, S3, S4. Can you see the way I wrote my number? I will now be like, sorry, where is my S1? This is 1, 1. This is another 1. This is my S2. This is another 2. So I will just assume that this is my S1 of reference. This is my S2 of reference. Do you get it? S3 and S4, they are actually in between them. So look at it. This is where my S1 is. I've already marked this one. This is my 1. This is where my S2 is. I mark it here. This is my 2. So I will write 3. It's 3 I will get before I get to 4, before I start 1 again. So the question will ask you, where will you pick S3? They will now label something here. Option, they will just put one option close to S2 here. That is where your S3 is. So it's just you to arrange the number. It's just a rule of arrangement. That's all. Just arrange it and pick it. Arrange it and pick it. That's all they want you to do. Arrange the number and pick it. So S3 will be here. S4 will be closer to S1. And that's all they need you to. And no one is saying that, no, just pick it. Like, just arrange the number. 4 is closer. If you look at it here, 4 is closer to 1. 3 is closer to 2. So if my 2 is here, my 3 will be closer to. Just arrange the number. 2 3 4 1 2 3 4 1 2 3 4 1 1 1 2 3 4 1 2 3 4 1 2 3 4 1. That's how you arrange it. So that's all. Because they love to ask about where will you pick S3, where will you pick S4. So if you are not very careful, you will just be looking for what is not lost when you are just supposed to look and just pick it. All right. So that's that. The last but not the least here is about the cap. If the question does not flow with S1, S2, S3, S4, where the mitral valve is closing, where the aortic valve is opening, and blah, 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 the question may be related to what do you think is the diagnosis? When you see the cough like this, cap it. So you cap it here, you put your C here, you put your C here, you put your A here, you put your P here. This is a cap, you see, when you wear a cap. This is the head of the patient, and this is the mouth. You just cap it. So what this means is this. Let me clean it for you to get it better. What this means is that if you notice that it is this side of the cuff that is bulging like this, your answer will be related to contractility. If it is the upper part, the superior part here, that is bulging up, your answer will be related to afterload. If it is this part here that is bulging out like this, your answer will be related to preload. Now, let me give you an instance. I look at the cuff. They give me this cuff like this, and they now give me the one for the patient. The one for the patient is like this. Can you see? If you look at it, the thing is this side that is bulging out here. My answer is there is increase in contractility. If they give me something like this, I just look at it that this one is shooting up. I will be thinking more towards increase in afterload. What can make afterload to increase? Maybe arterial pressure. Arterial pressure is high. Maybe I'm dealing with aortic stenosis. All those stuff that can be related to afterload. If I look at the question and the cuff is more or less like this, can you see? It is this side that is bulging out. My answer will be related to preload. Just cap it. So tell me what is difficult in that. So you don't need to be looking for too much stuff. Just pick simple thing and just start looking at questions with that eye. You are most likely going to be relaxed in exam than for you to want to explain so much. When you want to explain so much, you are going to miss a lot of questions. And that will make USMLE to now start looking difficult for you because you will not be able to think simply again. All right. Good one. I hope we have already picked one or two things. Did we learn one or two things, even though we can't go beyond this? Did we learn one or two things? Oh, that's fine. So that's a very good one. So as we will be stopping here. So as we rightly said the other time, find a way you can get across to us for you to. Dr. Abali is here. Dr. Abali.
Yes, you.
So
I'm here.
This is Dr. Babali.
Good evening, everyone.
I showed you Dr. Babali the other time. So, Dr. Babali, do you have one or two things to say before people start escaping one by one?
No. I'm okay.
It's all right. So that's my partner. Basically that's that for you. Find a way you can get across to us. Yes, of course. Yeah. We are going to increase everything. The speed will be increased. So within a day, Dr. Assumpta, if anyone has my number, you can put my number or Dr. Babali's number there. So if at all anyone wants to, in the message box, so if at all anyone wants to get across to us, please don't think USMLE, irrespective of when you left med school, it's not that big of a thing. Both 1, 2 and the like, so they are not big. Do you get me? Just look at them in a very, very simple way, and we have your back. So get across to us. Any question from anyone before, because this is just a day webinar, which we feel that at least we achieved something. So any question from anyone for us? Anyone?
Please, can someone drop a number that we could use to contact you if we have questions about the review?
Yes, someone can please drop our contact. Then let me say this: if you are going to really enjoy us very well, like bring your USMLE problem, that headache you think you are having. So bring it, drop it. So, and try to use the material. What you will get out of it is actually beyond your imagination. So people have problem with us because they themselves do not really, they are not neither here nor there. So they are just floating around. So they pick this, drop it, pick that, drop it, because their minds are not settled. They are always thinking big because they listen to a lot of motivational speeches that think big, think big. They are also thinking big, big questions, and they think that that is what the exam is all about. So it's not like that. Like very, very simple ones you are going to see, and that's really going to help you. So please find a way to get across to us. If by tomorrow, for those that may want to join our step 2, that's we are going to be doing a step 2 webinar. So we break cardiology down to in step 2. So you can actually come if at all you wish, just for you to have an idea of how the what do you call it, how the exam for step 2 is. You realize that there is no significant difference between 1 and 2. So, and that's that. So thank you so much, everyone. Let us enjoy the rest of the day. Bye.